So, good morning, everybody. Welcome to today's meeting of the Public Services Scrutiny Committee on Monday, the 7th of July. Sorry that we're slightly late starting. Some traffic in Usk related to the bridge has delayed some of us, but we're here and we're joined today by an Iron Bevan Health Board representatives to discuss two very important subjects, which are adult mental health services, focusing on adult suicide, and then care for people in the community with dementia. So the first item on today's agenda is to elect a chair. Please could I have nominations and secondaries for a chair? Councillor Dale Rook.
I'd like to nominate Councillor Armand Watts as chair.
Okay, do I have a seconder?
I'd like to second, please.
Okay, and we also have a seconder in the room, but seconded by Councillor Joe Bond. Okay, I'll let the new chair, Councillor Watts, appoint our vice chair. I believe we might defer it, but he will take us through the agenda.
Hazel, thank you all for electing me again. It's been a pleasure to run this committee for the last 3 years, and we've tackled some really interesting subjects. We're tight for time. I'm not going to I'm not going to grandstand, but we've got a really good committee, and you'll see that as the meeting evolves. And we've got some really good members on here, so it's an absolute pleasure to chair this committee. The next piece of business would be to elect or appoint the vice chair. However, the Penny, who has effectively put herself forward again to be vice chair, who I might say is an excellent vice chair, is unfortunately not with us today. She's otherwise engaged. Maureen is standing in for her. However, we can't elect Maureen as the deputy chair because she's a busy lady. So essentially, we're going to defer that. If everybody's comfortable in the meeting with that, so we defer the appointment of the vice chair until the next meeting. Please confirm by saying aye, or just putting your hand up, or just acknowledging that. Thank you. That's right. So we'll do that. Next on the agenda, the business of apologies for absence. Have we got any apologies for absence?
Yeah, we have apologies from Councillor Penny Jones, and she's been substituted today by Councillor Maureen Powell.
Okay. Have we got anybody here then that's not here that should be here? Have we got Frances here?
Frances isn't here.
Frances is not here, so okay, she may join the meeting, as Frances sometimes does. Declarations of interest. Have we got any conflicts of interest, any points of interest that you need to have run by me at this point, or will need to run by me? No?
Very much an old age pension.
So Maureen, yeah, we're almost going, yeah, sorry, yes, go on, Jill.
So I'm on CLICE, which is the Iron Bevan Unitary Health Board, CHC equivalent now, CLICE, so I don't think it impacts on this situation.
So you think that's, so we'll mark it down as a non-prejudicial interest, so you would need to then obviously, you should need to fill a form out for that at some point. Okay. Are there any other potential conflicts of interest? Thank you for that, Jill. Any other conflicts of interest now? No. Public open forum. Have we got any members of the public here? No? No. Okay, so that's next on the agenda. We do have a number of other elected members here today. So I can see already we've got John, we've got Sue, we've got Jackie. Good morning. Are there any others that I can't see on the camera? Oh, and then we've got Emma as well. You're all very welcome. It's nice to see you at this select committee meeting. The normal format is you know, and Simon, good morning, Simon, is that I will normally let the members of the committee speak, and then I will then bring you in for that. So we will effectively, you know the process because you've sat in these committees before, so you'll all get your fair hearing. And then obviously we've got also Mine today as well. They're here in the meeting as well. So welcome, Mine. Thank you very much for coming along. You do some excellent work in the community, and we're grateful that you're here with us today. There are 3 people from, I'm getting my notes, there are 3 people from Mind who are, is it Sarah Davis, who's the director of Mind, Megan Escott, who's the project manager, and then we've got Is it James? I can't remember.
Jamie.
Jamie, sorry, I need new glasses. Devlin, who is the Head of Housing and Tenancy Support Living Services at Mine. So welcome all of you to this meeting. Right, so we've got two really big issues that we've been very patient about trying to get onto the agenda, and then organising this is been in the scheme of things okay-ish, but it was important that we get this done. These are issues that are close to most of the people in this room's hearts. People have got experience of that, and I know certainly, as far as the wider community and our constituents, are very, very interest to, I guess, members of the public. So effectively, what I'm trying to say is that they are issues of significant public interest. First today on the agenda at number 6 there, we've got, we're going to have a kind of discussion. We're going to ask some questions of an Nairn Bevan Health Board in relation to adult mental health services and a focus on adult suicide. Today we've got, as I say, an Nairn Bevan. We've got Liz Andrews, who's the consultant clinical psychologist. Good morning, Liz. And then we've got Louise Turner, who's the director of mental health, as well from an Nairn Bevan. So welcome both of you to today's meeting. I hope you're all relaxed and you've got your water. We haven't got any nibbles or anything like that. But thank you for coming along. The floor is now yours. What we're going to effectively do is we're going to let you open up. You're going to tell us what you do, and we're going to ask you a couple of questions. But we're all really nice, I promise you. So, over to you.
Thanks very much. Well, firstly, thanks for inviting us. It's really good to be here.
Oh, thank you. Thank you. I was just saying thank you for inviting us, for giving us some of your time for, as Councillor said, a really important subject. Lots of what I'm going to present, I suppose we made some assumptions about what you might want to know, and we've left plenty of time for questions. We want to share with you some of our learning as a health board about suicide amongst adults. Yeah. But before we go into lots of the facts and figures, and I promise I'll explain some of the acronyms, I realise they're really distracting. Also, the slides get really full if you write it out in full all the time, so we'll make sure we speak to some of the acronyms. But before any of that, I just want to say that we know that lots of people in our communities will be affected by mental health. Many will also be affected by mental illness, and it would be unusual to get to this stage in any of our lives and to not have heard of or be affected by a suicide. And it's tragic, it's always tragic, and whilst we're presenting facts and figures, it's really important to remember that behind each of those is a human, and behind each of those is a family and a community. So I suppose I'm inviting you to take some care of yourselves as we have this conversation, and I'm a clinician, so hopefully I will do it as sensitively as I possibly can, but obviously I don't so just an invitation really to bring in passion to the subject.
Yeah.
Microphone's gone off.
Yeah, sorry, your microphone's... Can I also say as well, would you mind just moving the microphone a little bit closer to you? I know it's a bit... There you go. You got it.
Did you hear any of that?
Most of it, but okay. It was good. It was fine.
Okay, so just an invitation to be, to be cautious with yourselves. So we've got some slides. I'll do my best to talk us through these and then leave some time for questions. So hopefully that is sharing with you all now. And actually I can now hear when my microphone's on, so Louise doesn't necessarily have to assist me too much. Okay, let me present this as a slide. It's a little easier for me to learn. Okay, so the aim here is really just to talk you through what we do as a health board and how we learn about what we refer to as sudden and unexpected deaths. The term SUDS, sudden unexpected deaths, actually encapsulates lots of things, one of which will be suicide. But it can also be a death that we weren't expecting, either by virtue of the person's presenting problem or by their age or out of context of their illness. So all sudden and unexpected deaths are identified and reported in the health board through direct reports. So that would be if it comes to a clinician's attention. So I'm providing care for somebody and it comes to my attention. But also reports from partners. So it might be that somebody in the local authority has become aware, or it might be that police have become aware. And we're also alerted by the coroner if there's a death that we need to be aware of and we need to bring some scrutiny to. Under the umbrella of sudden unexpected deaths is suicide, which is the act of somebody taking their own life intentionally. And I say that because it's really important to understand that definition, because very often somebody might appear to have taken their own life, but there isn't evidence, as the coroner would see it, that that was their explicit intention. And so sometimes the facts and figures around suicide can perhaps, I suppose, not mirror what the community or the family's experience is. And that can sometimes mean that we need to bring kind of extra care around those areas in helping families come to terms with an unexpected death of somebody that they cared about. We have a number of layers, I suppose, in terms of our learning about suicide, and one of them is the National Confidential Inquiry into Suicide and Homicide, which is a body, an agency that is associated with Manchester University, and they are able to take all of the evidence from multiple sources all across the home nations, and that allows them to benchmark around the prevalence of suicide in our communities and in our home nations, but also to bring learning to that. So they are a group of clinician academics, and it means that they bring rigorous learning and they can produce national themes. And that means that locally, when we scrutinise our data, we've got some comparison points around what we're doing well, so where we look favourable to national benchmarks, and also where we need to improve. There's some newer developments in Wales, and you'll know, because health is devolved in Wales, that we're able to have some autonomy over some of our strategies. And the RTSSS, which stands for the Real-Time Surveillance Survey of Suicide, essentially is a way of capturing data as it happens. So the way that suicide historically has been reported is that there would be a death and then that would need to be investigated, and only the coroner can deem that that is a suicide, and there's a number of factors that the coroner is looking for to satisfy their requirements of that being deemed a suicide. That means that often health boards and partner agencies miss out on learning. It also means that we miss out on the opportunity, if we only respond to an official suicide, of supporting communities as well. So the real-time surveillance survey for suicide allows us to engage with partner agencies, and there is a national platform where deaths that are unexpected and appear to be suicide or appear to be intentional are captured so that we can have immediate learning. And obviously there's some caution and caveats around that. So what do we do as a mental health and learning disability service? So I'm sure that you're familiar with our services, but in brief, the Mental Health and Learning Disabilities Division provides a range of services, which includes crisis prevention services and crisis response services. So most recently, the 111 Press 2 service, where you can access mental health practitioners rather than physical health practitioners or practitioners that specialise in physical health. Our primary care mental health support services, which are accessible and sit within GP practices, and then secondary care services for people with mental health difficulties, often more severe mental health difficulties, and learning disabilities. And that's all within the adult range, so anybody over the age of 18 and those transitioning into adult services. There's also a number of specialist services for drug and alcohol use, veterans, liaison services in the Grange Hospital and Neville Hall, and for those that have committed crimes, forensic mental health services. All unexpected deaths of people known to our services in the last 12 months, so even if they're not in regular contact with us or they've only had one single contact with mental health services, are captured and are reported as a serious incident, and all of these are treated as a sudden unexpected incident or a serious unexpected incident, and they're subjected to scrutiny and learning, and we do that for every single person. So it's case-based learning, and then what we're able to do is stand back from what we're learning from the individuals and do more thematic learning on a group basis. In relation to suicide, as I said, there can often be a delay in terms of a conclusive verdict, and we wait on the coroner, and so it's really likely that when we're looking at sudden and unexpected deaths, because we haven't had a formal verdict of suicide, we're actually overestimating the incidence of suicide. And that's because we're seeking to be inclusive in our understanding. So in terms of the Welsh Government data, the real-time surveillance survey, and again, these are figures, but it's sad. So I invite us to notice that whilst they're their numbers, they're also humans. So there were 356 deaths by suspected suicide of Welsh residents who died in or outside of Wales, giving us a rate of 12.6 per 100,000 people. This has remained the case for years, that males appear to be at significantly greater risk of dying by suicide, and the age-specific rate was highest in males who are 35 to 44, followed by younger men, 25 to 34, and by area of residence, Mid and West Wales had the highest rate of death, and you might have some interest in that because some of your borders will touch on those areas. It's really important that we distinguish between somebody deciding, and I hold that loosely, somebody often isn't in the right frame of mind to make that decision, but setting an intention to take their own life because they're experiencing a severe mental illness, they're hearing voices, or they're severely depressed, and people who take their own lives because their problems outweigh their capacity to cope. And what we're identifying is that suicide is often seen as a public health problem rather than a specialist mental health issue. And so here we highlight some of the social factors that are associated with suicide. It's often correlated with living in the more deprived areas. It's often correlated with rurality, again, an issue affecting Monmouthshire, and often in people that are unemployed. And our own data suggests often in people who are not in a relationship and don't have that as a protective factor. 74% of the deaths detected by Welsh governments in the RT-SSS were in people previously known to the police. Again, that's often an indicator of social adversity rather than something about those people. So mental illness, which we discriminate between mental illness and having problems with your overall mental health, was a factor in 47% of those identified as dying by suicide. Alcohol and drugs in a little under a quarter. Being a perpetrator of domestic violence, again something that I know the local authority will be working on, and having a long-term illness and the things that are associated with that, such as chronic pain. That's a really fancy graph, if you can see it. So at the top of that is the highest prevalence of things that are affecting people that have died by suicide as detected by the Welsh Government platform. So just kind of focusing down locally really into Aneurin and Bevan, it really matters to us. So we conduct deep dives into any sudden unexpected death, and in particular we've been over the last few years looking more closely at those who take their own lives. And we've conducted a comprehensive review, which we now revisit twice a year, looking at any particular hotspots and trends. So I wanted to share some of that with you. This is just a run chart that shows that there's variability in the number of people that take their own lives each month. And you'll see that there appear to be some months which are higher, and that really attracted our attention, and rightly so, our scrutiny. So we've had a look into that to see if there's anything for us to learn. Often it can be things like reporting in the media. It can be particular times of year associated with young people experiencing exam stress, or it can be to do with national events as well. So it's really important to bear those things in mind. But in fact, we didn't find, this is the second tranche of data that we looked at last year, we often didn't find a kind of seasonal pattern or link with kind of major social events. I can talk you through these really briefly. They mirror the national data, which is essentially that in all categories, more men than women are taking their own lives, other than in the category of women between the ages of 66 and 75. We note that there's a number of young people losing their lives to suicide, and that is obviously of high importance as well. There are no particular trends in terms of months or seasons. There's considerable variability from month to month, and it didn't really help us kind of elucidate any trends. And as I said, it mirrors the national trends. The vast majority of people who've died locally by suicide were not in a relationship, according to our records. So they're often people who have got limited social networks. That data is not always reliable. Essentially, we take demographic data on people's entry into the service, and often are not kind of reviewing that every week, because it would feel intrusive when you're trying to manage someone's mental health to keep checking their relationship status. Often it will come to us and we can update it, but we need to just hold that with some caution. And in terms of ethnicity, again, our systems are not brilliant at capturing this. It's something that we are working on. 64% of those that were confirmed to have died by suicide were from a white ethnic group. And it's important that we think about that, and you might have some questions about it, so I won't preempt your questions. Perhaps I'll foreshadow them. And then this just talks about clinical needs. So is there an area which we're not, we kind of might expect to pay some more attention to? And I guess what I would pull out of this is that the national data reflects that people with a diagnosis of personality disorder, who one of the symptoms is wanting to die and making frequent attempts to die, are at the highest risk and the highest prevalence of dying by suicide. And in fact, that isn't the case locally. And I guess our curiosity around that is that we have really well-developed evidence-based services for people with a diagnosis of personality disorder that respond across the range of severity. What we do find here is that those people who have got what's called an affective disorder, so essentially depression or anxiety or severe problems with mood, and those that are using drugs and alcohol appear to die more often by suicide than other diagnostic categories. You might, as a local authority, have an interest in neurodiversity. I know lots of people, it's a growing area of interest. In fact, although the national data suggests lots of people with neurodiversity will feel overwhelmed by their lives and by the society that they live in and take their own lives, that isn't reflected in our local data. That may be a data issue, but we don't think it is. So there's a number of diagnostic groups where this is more prevalent. I've said this: affective disorders, psychotic disorders, and those using drugs or alcohol to manage their distress. And then in terms of the geography, which I think would also interest you, in fact, when we looked at this in our first study period, 2021 to 2023, even when we corrected for the size of population, so this is pro rata data if you like, Monmouthshire came out as the highest prevalence. Now, in terms of what we might predict, you might guess at some of that. You've got rurality, you've got some areas of deprivation, there are some pockets where there is quite a lot of drug use, often to do with kind of social disadvantage. It obviously was of concern to us, and it's something that we have looked at. When we looked at it in our 2024 analysis, that wasn't replicated. The deaths that had occurred in that period were not related to suicide. They were sudden and unexpected deaths in older people, and we still deem that an unexpected death if it's out of the context of their illness. So we don't say just because you're older, we don't capture any learning from you dying. So I suppose to give you some assurance about where we are as a health board, the National Confidential Inquiry, from their thematic learning, will suggest some things that health boards and their partners should be looking at in order to improve quality and patient safety. So the first thing is that we've got clear processes around recording any sudden unexpected death, in particular suicide, but also suspected suicide, so we're as inclusive as possible. And let me explain what this means. So we do that in a multi-professional way. So if it was only, for instance, a psychiatrist looking at that, they might look through a medical lens. We try and include all professions. We're really lucky that we have nursing, social work, occupational therapy, psychology, medical colleagues, and all learning is looked at by all professions so that we're as inclusive as possible in considering how we need to help people when they are in a suicidal crisis and how we can improve the likelihood that someone will choose to live. We can also self-assess against the toolkit that's provided nationally by the University of Manchester, and they indicate these various points. So having safer wards, and I'll leave you to ask questions on this if you've got them, early follow-up and easy follow-up after discharge from hospital, not admitting people to other hospitals out of our area. So for instance, if our beds were full, we should really avoid admitting somebody to Bristol because they're away from their care team, they're away from their family, and that's been associated with people taking their own lives when they leave hospital. 24-hour crisis support, which obviously we do. Involving family, which we have a strategy for, that's been part of our learning over recent years. So involving family when people are in an emotional or a suicidal crisis. Personalised risk management plans, which we also do. Having outreach teams, which we also have as a health board. Efforts to reduce alcohol and drug use at all levels, so as a local authority, within the community, within kind of partner agencies and third sector, and also within our specialist services in the health board. And then managing self-harm, including how that's responded to in schools, in communities, and in our hospitals. So we assess well against all of those factors as a health board. There is some more that we would like to do, of course. It would be strange if we had done everything really well and people were still taking their own lives. So there's some more that we're working on. We want to get better at routinely monitoring depression, and that's in particular for people who've got physical health problems. So the NCISH data talks about people who have got long-term physical health problems, for instance, with their digestive system or with chronic pain. So actually those people don't fall under mental health services, but our job is to advise through other health board structures how that might happen in physical health settings. We're looking to work on improving the interface between drug and alcohol services and mental health, because that doesn't always come together as neatly as we would like. And we'd like to reduce variation. So COG is a co-occurring needs gateway. It happens only in Newport. So Newport Local Authority funded this, where they had a recognition that lots of people that are using drug and alcohol find it hard to address their mental health because they might not have a permanent residence. They might have complex co-occurring problems, for instance, with their physical health, or they might be a member of staff, and so they've got too much shame to ask for help with drug and alcohol problems. And so the co-occurring needs gateway is a small multi-professional group that involves all agencies working across multiple levels, and they come together to discuss particular cases, and they work assertively and proactively with those cases in order to reduce risk and support recovery from drug and alcohol use. Because of the way that it's funded, it's only happening in Newport. And it would be really good to reduce the variation of that across the health board patch. But because it's funded in partnership with other agencies, multiple agencies, it isn't happening elsewhere, although Caerphilly are keen to work on that. We are committed to adhering with the evidence base for intervention for people experiencing a psychotic episode. So our early intervention for psychosis is often for young people, sometimes for older people that are experiencing their first episode of psychosis often being a recurrent illness. But actually we want to do better in our community mental health teams, so to have some of the principles like a spirit of hope and really good therapy for people experiencing a psychotic episode, and we're definitely working on that. And I just really want to highlight that prevalence of the men taking their own lives. And in the time that I've been qualified, that hasn't changed, and it's on an upward trajectory, even though stigma around mental illness is reducing all of the time. And so I suppose we could think about that together, and you might have some questions or thoughts on that, and I'd really welcome those. I know Louise would as well. Just to say, suicide isn't always underpinned by a major mental illness, and if I could leave that with people today and you take that into your communities, that would be great. When we look at the national data, 25% of people taking their own life are known to mental health services, so 75% of people aren't. So that's our communities in Gwent, and so that's schools, it's churches, it's local volunteering groups, and so it's also true that it's in other areas of our health board. I suppose I just wanted to leave this message really, is that suicide is an act that occurs in the context of stress that outweighs the person's ability to cope, and sometimes that means that somebody won't have symptoms of a severe mental illness. We know that suicide can occur outside of mental health systems: complex physical health needs, chronic pain, bullying in schools, social contagion, which means essentially where something's reported in the media and other people copy, and those using drug and alcohol services that aren't known to mental health services. And with this in mind, the Health Board has access to interventions that are designed to enhance coping in lots of specialties, including for our own staff who might be at risk, and I'm sure you've also got employee assistance programmes. So we have an alcohol liaison service that sits in A&E that helps people with alcohol use that aren't known to mental health services. HEART is our own in-board service for our staff that might have problems with drug and alcohol, and obviously we've got public health as well. And because this might affect you, or it might affect people that you care about or love or know, we're just leaving you with some resources so that you can use those in your communities, or you can investigate them when you've got time. All of these are just really rich resources, and I'd encourage you to have a look at them for your own well-being, but also for those around you. And I think that's it. I haven't checked the time. So I hope that's okay.
That was an amazing presentation. That's probably one of the finest presentations we've had on this committee in the last 3 years. Well done, Liz. I'm so impressed with that, really, that you've raised so many interesting points, and I know there are some really interesting questions that will be put before you. So I'm going to call on members of the committee. So I'm being so Jill, you'll be pleased to know that Hazel's already informed me that you're first up for the questions. So Jill, the floor is yours.
Yes. Did you say that we had some Mind representatives there as well?
Yeah.
No, not today.
Yes, we do.
Yeah.
Yes, we do. Yes.
Right. Okay, great. Thank you. That's wonderful. Thank you very much, Liz. Can I call you Liz?
Of course, yeah.
Yeah, thank you. Thank you very much, and also Louise. Great report, and the way that you presented it so sensitively for such a difficult subject. So I'm sure that you're both very competent and very able in your fields. Thank you very much for all that you do. So the data was very much in the past. Is there any more up to date data? Are you waiting for coroner's reports, or everything, all the other information to come back? You said that you've had, what did you say, RTSSS? Is that the up to date? You said the the up to date information that you can see. I wonder if there's anything else you can share with us, or whether that's contained in the slides. The pandemic was a factor in some of the information, or some of the peaks that were involved in the data that you have shared, because it didn't mention that, and I wonder if that's got anything to do with it. The second question is around, please, the graph on page 10, which is, there seems to be an awful lot of unknowns.
Yeah.
I wonder if you could, perhaps it's quite significant, and perhaps a third or greater than a third often. I've done it again. And what you think that might be, but also you've mentioned local. Where is that local? And the third, but a subject close to my heart, because I'm a psychotherapist, I volunteer. Is it? You talked about resilience and coping, and is it related to the attachment attunement, prenatal and early years, the ability to cope and societal pressure? Obviously, as we know about secure attachment, resilience, and the willingness, or the capability, or the aptitude to, or the situation, being able to ask for help in times of need. So is there enough provision? Have we got waiting lists with yourselves in mind, and can we refer to low cost services outside that? Can we do some more to share needs for better attachment attunement? For example, my often raised issue is, can we help prenatal more, and in relationship sessions for the young people in school, so they understand, don't just put an iPad in front of you, you've got to develop the young person's brain, the child's brain, and a social emotional learning in schools, all these different things. I know it's not perhaps your area, because you're unfortunately dealing with the sadness that comes from not such good environment, or starts in life, maybe, or trauma throughout life. So
yeah,
answer any of those, please. Thank you.
Thank you, Jill. Sorry, just before, Jill's quite rightly chipped up there and said that although it wasn't my intention, even though I did introduce them, so we have got members of Mind. So what I'm going to do is, before you answer, is if Mind want to come in at this point, what I was intending to do was, so apologies, Jamie and Megan there, I can see you on the screen. If you want to come in and interject at any point there and answer some of these questions yourself, please feel free to do so. Let's try and keep this, because of the nature of it, let's try and keep this as casual as we possibly can. Yeah. Thank you, Jill. Thanks.
Awesome. Thank you. Shall I answer those first?
Yes,
yeah.
please.
Okay. Okay. gosh, Jill, I think probably you and I should just have a cup of coffee for a couple of hours outside, and I might get around to answering all of those. Thank you so much. They're such interesting questions. So I'm mindful there's lots of hands up, so I'll do a bit of brevity, but I'm always really happy to be contacted as well. So if there's some stuff that we don't quite address. So I think your first question was around more contemporary data, so kind of what's happening right now. So we look in retrospect. We've just had an invitation this week to look at the data from the last half of last year. So we're going to look at that, and that will be available by the end of July. So we have a database, and I quite like to bring quite a high degree of scrutiny to it. So it just means we need to do a little bit more research on it and look closely at some of those variables. So that will be, we report to our mortality group, so that will be coming out at the end of July. I haven't had a close look recently at the RTSSS, but I've sent the report as part of our preparation for coming here so that you can all access it. Our public health and our mortality group look at that data all of the time and alert us if there's an unusual trend that we should be aware of. The last time I checked, Anira and Bevan fares well, so Gwent fares well in comparison to some other regions. And that's okay in terms of some assurance for us, but that doesn't mean that we shouldn't be looking at every death and learning from it. So I sort of hold both things. Like on the one hand, it's good not to be an outlier, and we also want to bring that kind of detailed learning. So we'll be doing that detailed learning now. The pandemic, that's a really interesting question. I can tell you what I know from NCISH, so the National Confidential Inquiry. When they looked at the data from the whole of the UK, COVID appeared to be protective in the first 12 months. So I think there was all of us saying we're going to have a mental health tsunami and people being locked in and people being isolated. COVID did some really difficult, damaging things, didn't it? And then some of the things that were really protective were around a sense of community, around families needing to be together, around schools reaching out to the most vulnerable, local authorities reaching out to the most vulnerable, which in terms of attachment and attunement needs, let people know that their vulnerability was noticed. So I think in that lockdown period, we had a significant dip in the number of people taking their own lives. What's happened since is a small peak. And the data that I had a quick look at the weekend, you have to forgive me because I was on leave last week, so I had a quick look at the weekend as I came back from leave, is that there appears to be a slightly concerning trend around young people, which of course is a division we don't look at and as a health board is of interest to us. So I'm sorry I can't speak too much to the data, I just haven't had a chance to scrutinise it. But our young people still are disproportionately affected by COVID, and there's multiple factors around that, and my child psychology colleagues can speak to that much better than I can. I think what we understand is that early interaction that was missed for babies and young children at that time is now showing itself in terms of how they settle in schools, and schools are already stretched, and they don't have a massive amount. I'm a school governor as well, and they don't have a massive amount of well-being support. They don't have a lot of educational psychology provision, so it can be tricky, I think, to address that. I'm sure we can debate some of those other thoughts. So graph 10, you were saying about unknown. It's really frustrating. I was incredibly frustrated by that data, and I can also tell you that I looked at every single data point. So unknown meant that we had an idea about how somebody died, but we didn't know why they died, if that makes sense. So I could tell you that a number of people died from kidney failure, that they died from a kind of sudden unexpected death, but we couldn't explain physically, but there was no clear evidence that it was, for instance, intentional suicide. It was often things like misadventure, so trying a new illicit substance, and nobody knew what the person had taken, but they overheated. At Glastonbury last weekend, there was a batch of MDMA, and we've got 3 people in intensive care because of the nature of that substance. So these are things that are outside of our control and outside of our intelligence base, and it means that the data looks less than rigorous. But I promise you, I have scrutinised it, and I would know the reasons why people died, but we couldn't categorise them. What were your other questions? Resilience. Family and Therapies Division are doing an enormous amount of work. I'm really mindful that Jenny's here with me as a health visitor by background. And so we've got the Parent Infant Mental Health Service, we've got perinatal mental health teams. Our perinatal mental health team in particular are broadening to try and include dads. That feels really important. We know that dads also suffer when there's a new baby in the house. We know that the incidence of domestic violence will increase when women are pregnant and in the first year of the child's life. So there's absolutely a focus. I think there's a brilliant strategy in Wales around perinatal, so antenatal and also postnatal mental health, and they are fierce advocates for extending the current guidelines into maternal mental health rather than perinatal. So thinking about the 1,000 days, the first 3 years of a child's life. So I think probably you and I are closely attuned on these ideas, and I think we would love to see more in schools. What we're seeing is the impact of social media. So Stanford University have just released a paper where they asked people to give up their phones and social media, and mental health and well-being improved significantly more than any evidence-based intervention that we can offer. So CBT, medication. It's a huge study. It's Stanford, so it's really experimentally rigorous. And our young people are exposed to so much. And we can't take that away from them because it's the lives they lead. And what we can do is educate them around their relationship with social media and their relationship with themselves and their emotional literacy. So we leave that to schools, and we hope to reap the benefits of young people who become as self-aware and as emotionally literate as they can possibly be. Mind have run some amazing projects. They ran them in my children's schools around emotional literacy and well-being, including the ecosystem, so parents, teachers, absolutely phenomenal interventions, but of course are on time-limited funding. So yeah, it'd be great to weave that into strategies. I could go on and on. There's NEST. There's the NEST framework in Wales, which is phenomenal, nurturing empathic, safe and trusting relationships, which I hope as a local authority you're aware of. I think Monmouthshire often do better than most in terms of being aware of that, and your services for care leavers and young people who are vulnerable are often really well developed in Monmouthshire. So was that all of your questions? Was that all of them?
Yeah, I think so. I think she covered. Are you happy with that, Jill? Yeah.
Yeah. It was really the other information was around local.
What's local?
Local. What local mean? And also, so really, and I think our mine colleagues hopefully about whether we've got sufficient. I know wonderful things are being done, but is there a funding issue and we've got sufficient resources? Thank you.
Thanks.
Thank you, Jill.
Local is Gwent, so the Aneurin Bevan footprint.
Marianne.
Yeah, thank you, Chair. Thanks, Liz. Thanks for that presentation. One of my questions is a bit of a technicality, really. So at the beginning of the report, you referred to 356 deaths in Wales, and then on page 8, I'm following the graph there, and it doesn't quite match with the figures. So is that because it is a local? Is that referring to the Greater Gwent area? Is it?
Great question. So the 356 is from the real-time triple S, the real-time surveillance survey. So that's Welsh Government, and we use slightly different parameters. So when we did this study, if you like, if I can call it that, we were trying to triangulate data. Right. So we can get data from the police. Real-time Triple S had just come on board, and we had our own local health board data. So that first slide refers to RT-SSS, and the slides onwards then are our local data, so what we collect locally. So once we triangulated it, we looked at our own data, where we have slightly higher numbers because we're more inclusive in our definitions. And that 256 deaths is from all causes, so it wouldn't just be suicide, it would be physical health as well. Okay. Yeah.
I've got a few other questions as well. Sorry, I was writing them down as coming along. So farming community as well. Is there any data around that, especially being Monmouthshire, being quite a rural community? Be very interested. Safer wards, could you expand a little bit on that and let us understand as ward members? And then the initiatives, how effective are they? And I know I do the Movember every year, so it's just bringing awareness. Are you finding them effective, or is it?
Yeah, thanks. That's really good. So I have to remember all your questions now. So farming communities. So when I looked at the data, I don't think I would be able to discern whether somebody was a member of a farming community. What we know about the demographic trends is that rurality is important. And Manchester, so NKISH, sorry about all the acronyms, so the academic group in Manchester, they do look at trends in terms of professional grouping. And farmers used to be very high. Currently, it remains doctors, vets, really sadly nursing, and most recently construction workers. So they're doing some more research into construction workers. What do all of those things have in common? And suicide is complex, and that's really important to acknowledge. It's often access to means. So one of the difficulties with farming communities not only is isolation and obviously the kind of financial stresses and the current climate that farming is working in our country, but also that they have access to means. So I don't like to talk about means too much because, well, the evidence tells us not to, because it can be contagious. So I'll leave it at that, but I think you would imagine. And so what I think that means in terms of if we were going to intervene, that's not about giving access to mental health services, it's about communities. So it's about things like young farmers associations. One of our assistant psychologists I was sharing earlier is a psychology graduate. He hopes to go on to be a qualified psychologist. He's a footballer, very talented footballer. His brother plays for the Dragons, and they had a number of deaths of young men in their community by suicide, and one of them said, I'm not going to another funeral of my mate who's taken his own life. It's a Caerphilly borough, and so Jack set up what's called Jolly Brew Crew. So it's they come together in the leisure centre once a month on a Sunday. They drink coffee, no alcohol, and they talk about mental health and well-being and their community, and they're trying to enrich their community. And I've had the privilege of going to speak to them and spend some time with them. They invited me along, and it's amazing what that's doing for those men. And I think I come from Cornwall, so I'm very familiar with farming communities and fishing communities, and it is about how the community comes together, and it's about good gun laws and licensing laws and those sorts of things.
Come back on that one. I know a good family of the Ted Senior Foundation as well, which are going to universities and getting people talking about it in there, which is really vital. Sorry, the Safer Wards as well.
Safer Wards. Safer Wards is an initiative where essentially you look at the environment. I'm sorry, please come in whenever you want. I do love a question. It's about the environment that we care for people in. Now, unfortunately, in our local authority patch, and so Lower Monmouthshire will go into St Cadoc's, which is an older ward. Some of the local hospitals, so they have kind of more modern environments, but essentially it's about not having ligature points, not having isolated corners that people can go into. So ligature points being where you could attach something, where you could kill yourself, essentially. And so it's about the environmental safety that people are cared for on. And then there's something additional to that, which is around the culture of care. So around, being brave to have conversations, levels of emotional literacy, proactive engagement with people. So it's largely around the environment. And we have enormous programmes around that. I think you'd be shocked to hear how much we have to spend on those things. It's a lot of money, yeah.
Thanks, Miriam. Before I go forward, I assume that little bit at the end was your supplementary, yeah? So, thank you. Yeah, good questions. Yeah. I know that Jamie's sat there patiently waiting to chip in there. Jamie, the floor's yours. If you want to just come in at this point.
Yes, thank you. And thank you for your presentation today. It was quite interesting. I'm just wondering, do you have any data on the initial impact of COG in Newport at the moment?
Oh, we do, but I'd have to drag it out of my memory, Jamie. Yes, so essentially what we look at is a bit of a return on investment kind of methodology to evaluating it. So we'll look at, we've also got an enormous homelessness initiative in Newport as well, which interfaces with COG. So we look at things like A&E attendance, signposting somebody to the right place, relapse, reconviction rates, those sorts of things. And I can put you in touch with the psychologist that leads that, and Nigel Stannard, who's our local authority partner. They will give you much clearer data. But if I could give a headline, I would say it evaluates really well to the point that they recurrently fund it. And they've also just used their, I have to get the right term, I think is it HSG money, Housing Support Grant money? You lot will all know that better than I know it, to continue the funding around the homelessness project. So what we know is that if we reduce emergency evictions, and if we support people's, I'm going to say mental well-being, because often people don't identify as having mental illness, and we reduce re-traumatisation, that generally people are less likely to enter a suicidal crisis. So it looks at those sorts of factors in the evaluation. But I'm really happy to put you in contact with Bronwyn, and she can guide you through it.
That would be great, because part of my role is to oversee Newport, Torfaen, Blaen and Gwent and Monmouthshire, and work with the HSG grant with migrants and with mental health and homelessness. So yeah, I would be really interested in that. And another question for you: what are the plans to overcome co-occurring needs such as neurodiversity and mental health, or substance misuse and mental health across the county? Because what we are seeing, we currently work with 342 people a week. We can see these individuals for up to 2 years, but we keep coming across barriers where one service, such as social services and mental health, is saying we can't treat them because they're currently using substances. However, it's the chicken and the egg. Are they using substances because of their poor mental health, or do they have poor mental health because of the substances? And while those questions are being asked, people are being, I don't want to say failed, but they're not being supported in the way they need to be. So what kind of strategies are we working on to overcome those issues?
Yeah, I was going to say, so I'll let Louise, because we've got the ND strategy, and I'm encouraged by the new mental health strategy, but shall I let Louise speak to that?
Yeah, thanks. It's a really pertinent question, Jamie, I think. And this is where really the strength and the seamless working between strategic partnerships comes on board. So, we've got the Mental Health and Learning Disability Strategic Partnership, we've got neurodevelopmental strategic partnerships, and I think that's the work really strategically we need to do as partners as we move forward. So we've got a new mental health strategy, delivery plan, our suicide self-harm strategies. This is where our work collectively comes together to make sure that we haven't got those barriers between services, that we have got seamless support for people, and that we're working together collectively as a region on that. So I know that certainly from my point of view as the chair, as the Strategic Partnership for Mental Health and LD, that's some of our agenda moving forward. How do we make sure that collectively we're supporting people who may have co-occurring illnesses or comorbidities?
Thank you.
Yeah, thanks, Jamie. I mean, so I'm going to pepper this obviously with Mike, because they're a really important part of our community. So what I've got next is who I've got next, I should say, is Malcolm. Malcolm sat there patiently. Malcolm, the floor is yours. You're on mute. You're on mute, Malcolm.
Thank you, Chair, indeed. Thank you, Liz, for a wonderful presentation. As well as being a county councillor, I'm also a priest. I've dealt with families after suicide, I just wanted to make a point there, really. I get a lot of questions asked by family who have developed their own mental issues, such as, could I have done something to prevent this? Why didn't I see the signs? Why did I fail them as a family member? And of course, as a priest, the question I often get is, where was God in all this,
Yeah.
I get a lot of that. And families say, how do we tell the children of the community? What should we do now, These are the questions. We know in the farming industry there are financial pressures, there are weather-based uncertainties, and there's a general pride and stigma around mental health and the feeling of isolation. I just want to think that there's more support given to the rural community. I was very pleased that Marian brought the question up earlier on. But it's the questions that I'm faced with as a county council, but as a priest mainly, trying to sort of help families through a terrible situation. But I have to say, your presentation this morning has been wonderful. I certainly believe every day's a school day, and I've learned a lot today. Thank you for that.
Thank you, Malcolm, and for the work that you do in the community as well. I suppose that's the message that one of the messages that we want to give. I was on the way in this morning listening to people talk. It's obviously 20 years since 7/7, and there was a man on there talking about being in one of the bomb attacks, and he was talking about his faith, and he said that without God he didn't know how he would have got through, and he read a psalm out on the radio. So for some people, faith is an incredibly protective factor, isn't it? And the fact that they have people like you to be honest and say that they're maybe angry with God around that is really important, so that they can find their way through that, and communities can bring huge comfort. I suppose there's also something for me around our public health consultants, and they've developed some really beautiful resources. And actually, sorry, I think that's an oversight that I didn't list that, and really happy to send it to you, but it's called Helpers at Hand, and it's a beautiful document to help. We talk about it as people bereaved by suicide. I do a lot of that work. When we've had some learning, we always reach out proactively to support families, partly because we just should, like it's just the thing that should happen, and also because we know it prevents future suicides. So there's no gene for suicide, but we know that if someone in your family has taken their own life, you're more at risk of that yourself. And so it's really important that we do reach in. So thank you for everything you're doing. And, again, always happy to support people in those endeavours as well, as our public health consultants would be too.
Well, I do thank you for your presentation this morning. It's absolutely wonderful. I've learned such a lot, indeed, I know help is there, but I find with families, I have to stand in their shoes alongside them, and words are inadequate, we know that. But the fact you're there and just a touch on the shoulder or whatever, it does mean such a lot to families, but, there are no answers. It's the empathy we try to show and the love we try to exude to families. Thank you very much.
Thank you.
No, thank you, Malcolm. And you just touched on a word that doesn't really get spoken about in this committee, or in fact the local authority, the word love, Malcolm. So thank you for that. It's much appreciated. Right, next on it, we've got Maureen.
Thank you, Chairman. Two questions, one quite short, really. Do you find you have more suicides around the Christmas time because of people that are on their own and they feel lost?
Well, interesting. That's where I would have put my money as well, Maureen. But it seems to be after the summer holidays, and I've always been interested in that. I've often wondered if it's because a lot of staff take holiday in the summer holidays, so public services are on a slightly different, they sometimes feel like they're on a skeleton structure, and I've often wondered if it's just the stress of modern life, of trying to either be working parents and manage childcare demands. Again, that's something as partners we can all be thinking about, or sometimes so one of the things that happened in COVID for parents is, I think, so the referral rate for neurodiversity went up after COVID, because parents were spending longer with their children and noticing things about their children they hadn't previously noted, and wanted an explanation for that. And maybe that's autism or it's ADHD or whatever form of neurodiversity. And so I think in long periods where parents are at home with their children, it can often be very stressful. And again, it takes a village, doesn't it, to raise a family? And often we don't have villages. No. So again, encouraged by some things I heard on the radio this morning about encouraging encouraging, best start, flying start, Jill will be pleased about lots of that. So interestingly, no, not after Christmas.
No, because I
don't imagine there isn't a single case where that happens. I imagine there is, but it isn't a trend.
Because years ago, families didn't move away. There were families around,
Absolutely.
and there aren't anymore.
Yeah.
The other thing is, it's people having to cope with it happening. Friends of ours, the husband committed suicide. They were farming actually, and they got financial problems and other problems.
Yeah.
And she said, "How could he do that? He's gone now, and I've still got all his problems to worry about, and losing him."
And bereavement.
Now,
yeah.
I don't know whether you find people that are in that position, how they have to cope, because they've got to cope with everything now.
Yeah, it's multi-layered, isn't it? It's complex grief when someone takes their own life, and often it does evoke anger and resentment, and that's also a very difficult thing to say. And so the natural process of bereavement, of it being busy and you're arranging funerals, I think is already tainted. Often, and Malcolm will know about this, but often it's difficult for members of the clergy to know how to do a eulogy and how to talk about that, and so I think that just speaks to how complex it can be for the survivors of the suicide. It's happened in my own community on occasion, and obviously professionally as well. And I suppose, what can we all do about that? And I think we can be open to the possibility. We can be good at talking about our emotions. We can not cross the street, for fear of opening something up for someone. I work with lots of people bereaved by suicide, and I think they would always rather that we all talked about it, or at least asked, would you like to talk about it, and normalise being angry and confused. There are some phenomenal people out there who run support groups. So one of them is Non Jones's mum, Nikki Jones. She's in Cardiff. She lost her daughter to suicide. The Senior Foundation, phenomenal advocates for families, and I would encourage anybody bereaved by suicide to connect with them. They call themselves warriors, and I think that's a really fair name for them. I think they are fierce advocates.
Well, thank you very much. It was an excellent
thank you.
presentation.
Thank you, Maureen. Thank you both.
And I've learnt so much today. Thank you very much
Thank you,
indeed.
Maureen.
Thank you, Maureen. Thank you very much indeed. Tony.
Thanks very much, Chairman. And can I echo all the comments there about the presentation and the way it was put together. I'm fortunate that have been through training as a mental health first aider and have that qualification thanks to the proactivity. I work in banking, thanks to the proactivity of my previous employer, my previous role. And I had I was going to say misfortune, but I actually think it's the fortune that I'd had that training when a friend rang me up and told me that they were going to take their own life. And I was able to point them in the right direction. A first, it doesn't make me a specialist. It's like a first aid doesn't make you a doctor, but it enables you to have the understanding on where to direct things. So what you had to say in your presentation and the written one was refreshing, a refresher for me. And obviously from the comments from everyone else participating, how helpful it was. Just to expand a little bit further there, in terms of proactivity of being able to direct people, what sort of, social media has a bad name at times, but also it has some good points. So I was just wondering what sort of publicity about where to go might you be doing at the moment. My second question then was in relation specifically to bullying in schools. What proactivity is going on there with regards to resources going into school, because the pressures that the kids are under these days are far greater than we had, and also, sport, elite sport is one where there's one of the highest rates of suicide as well, and cricket being mine, cricket is one of them. Is there anything going on in relation to education to sports people as well in that regard? And sorry, my final question was, you'd mentioned, I think it was 70-odd% of those that take their own lives have got involvement with the police, or have involvement with the police historically. With the new Police and Crime Commissioner, is there any link up there taking place at the moment with her plans in relation to this aspect? Thanks very much. Sorry for those 4 questions.
Yeah, that's lots. I know it's like being in like an interview where you've got to remember the questions well, but Louise has really helpfully written them down for me. I'm gonna let Louise speak to some of them about kind of where to access, because lots of what you've talked about is at a public health level, and there's some amazing things happening. Of course, there's always room for more. Just in terms of the bullying in schools, because that would be outside of the Mental Health and Learning Disabilities Division, but an emphasis in the National Strategy for Mental Health on Early Intervention is really important, and I'd encourage the local authority and the clinicians that support the local authority, so they would be in our Family and Therapies division, to look at some of the research into bullying. So there's some really neat and cost-free initiatives that are seen to be protective in terms of reducing bullying. And some of it's around the culture of the school, and some of it is around things like having mixed year groups. So in your tutor group, you have members from every year, rather than have year 7, year 8, year 9. They're all mixed into one, and that evaluates really well in terms of being protective around bullying, as does having multi-year group extracurricular activities. So there's some lovely research that I'm sure your education team either have or could look into. I think that's really important. And then in terms of elite sports, I think there are people like me. I work with the WRU on a pro bono basis, because in case it hasn't come across, this really matters to me. And so I work with some of their elite teams and their national coaches, and do some work with their apprentices, doing what you've done, Tony, so assist, essentially. So just saying, be a good mate, ask people twice, tell people to wait, like don't make a decision now, hang on, speak to me again tomorrow. And often that stuff is much more effective than someone like me in my clinical role coming in, removed from your life, removed from your family. We were at a presentation recently. Louise and I had the pleasure of being with the mental health minister, and we got to hear lots of presentations from across the health board, and the Family and Therapies division were there, and the community psychology service, and again, happy to put you in touch with them. They work across Gwent. We're doing some beautiful work with Raglan Football Club. I'm sure it was Raglan. Yeah, it's now digging deep into my memory, where they have woven attachment theory all the way through the club. Absolutely, just really admirable work, and I'd encourage you to invite them here. But there's some brilliant stuff happening that is about addressing the factors that contribute towards mental health rather than trying to address the mental health problem. So yeah, I'll hand over to Louise to talk about some of the other stuff.
Yeah, thanks, Liz. In terms of access, and I think you said the promotion of where people can come to access support. Obviously, we have public health, our Mellow website, which is rich in resources. We've got our crisis services, 111 Press 2. People can access support through their GP, local primary care services. And I guess this is going to be the focus of our strategic work together with partners around the delivery of the mental health strategy, which looks at delivering open access. So this is about really essentially right person first time, and adopting some of those children's approaches around no wrong door. So there are a number of points that people can access us. But again, I think working towards, as partners, open access will be the kind of focus of our work moving forward. And I guess in terms of your last question around our Police and Crime Commissioner in particular, again, I guess this is part of our strategic work plan together, isn't it, through our RPB regional and also our PSB, about making sure that the agendas align, and that for people who have mental health difficulties, that we as strategic partners are focusing our work to support them in terms of delivering on that strategic remit.
Mm-hmm.
Tony, very much. It was very detailed.
Tony, it's unusual for me to do so, but I've just got a question, just to add on to that. There's not often I do this. So when we talk about strategic partnership, with, for example, the police, for example. If we know that, for example, that we've lost the I'm trying to think of the title now, effectively the police liaison officers. How does that work, though? I mean, it sounds great, doesn't it? But in reality, if we've got no direct link with the police, you've got no direct link with the school, we're specifically then relying on schools. Now, schools pretty much are what they are, but there are occasions that I've seen throughout my time as an adult where I've looked at governorships or I've looked at schools. The reputational impact of something very negative that happens is something that will allow schools possibly to stray. Now, I'm not saying that this is happens on a regular basis, but schools really care about their reputation as well, don't they? So how do we collectively, with the police, the local authority, you guys in Narren Bevan, how do we know, really, and what evidence have we got that we are then doing our very best within schools?
I mean, I could...
Sorry, Chair, was that directed at me?
No, it absolutely wasn't, Tony, because we wouldn't have the guests here, and you'd be, I'd be overwhelmed with your level of knowledge, really, Tony. But no, it wasn't.
Chair.
Yeah.
I am aware of scenarios in schools where, in my opinion, the reputational risk of the school was brought too much into the discussions and not enough dealing with or proactively dealing with issues. There was sadly a young lady in Monmouth Haberdashers who took her own, well, she attempted to take her own life, but subsequently died as a result of technicalities. But it seemed to be brushed under the carpet, and it didn't feel comfortable. So I think what you raise is a very valid point, and that liaison with the police is, as I get to, because I sit on the Police and Crime Commissioner Board, is trying to understand more about this, particularly with the 101 service that's available as well. Sorry, Chair.
No, that's excellent. You know what? You should have been a witness as well, Tony. Thank you very much. Sorry, the floor is yours.
I don't really know how to answer. I don't think I can answer your question, but I was thinking it'd be nice to share some thoughts. Just it's an invitation, I suppose, pushing it back to you. But I work with a group of young people to help with their political awareness. So it was essentially to encourage young people to vote. And we had a brilliant guest speaker, so I'll name him, Ewan Hilton, who's the CEO of Platform. And he came along, and we used to do this task with them where we would say, you're the kind of Prime Minister and you're the Chancellor of the Exchequer. Here's 100 pennies. How are you going to share them out amongst your government departments? So how much would you give to defence? How much would you give to education? How much would you give to sport? I don't know if you've ever asked that as a local authority, but it's really interesting. So they give a huge amount to sport and art and culture, a huge amount, and they give 20% of the budget to mental health. It's absolutely amazing, and they think that they can give just 1 pence to defence. So, I mean, these are young people. They haven't, in their generation, they haven't been affected by war in the same way that many of us have. And anyway, so it's really interesting. Anyway, Ewan Hilton came along and he said, take all of that away and take a whole system approach and put all of your pennies in one pot and ask what outcomes do you want to achieve as a community. And I suppose that's sort of answering your question was how would you know, and I can't answer your question, that if we co-own data and we work through, as Louise says, these kind of strategic partnerships, and we identify the outcomes that are common to all of our communities, when we make changes, when one agency or one partner makes a change, we should be able to monitor the impact of that. It's an academic task, so we'll leave it to someone in a university, but I like the curiosity to ask the question, and it's an invitation for us to think together, probably outside of here.
No, we are a very curious bunch here, aren't we? And that's why everybody's on this committee. Thank you for that answer. Sorry, Louise, I didn't mean to pick on you. It's just it was slightly, as soon as we step into jargon, there's something that, makes me feel, oh, hang on a minute. So, yeah, we've got, next on the list, we've got Steve. Steve.
Thanks a lot for a really interesting presentation. I'll just keep my question down to one because I know there's other people waiting. Malcolm talked about families and how they are impacted. I wonder what you are able to do with the first responders or people that are involved. I used to know, for example, the train driver, underground driver, who had several incidents of hitting people on the track, and he joined the Samaritans when I was at Samaritan, to help him kind of deal with it. So I just wonder how you dealt with police, first responders, ambulance drivers, paramedics, and how they cope with it after the event. Are they supported, and what kind of things do they do? And I mean, for example, Samaritans might be able to offer help to them as well, the Newport Gwent branch perhaps.
Yeah. There we are. So we have a trauma pathway lead that was funded by Welsh Government. So it's about improving the quality of interventions offered to people with post-traumatic stress disorder and complex post-traumatic stress disorder. So ours is Helen Penny. Every health board has one, and Helen leads right across the health board and across our partner agencies. So she will advise, for instance, first responders on their employee assistance programs and how they might respond if somebody has been involved in a sudden unexpected death, or if they're affected by the nature of their work and they're experiencing problems with their own mental health, in order to reduce the risk of suicide in those first responders. So as a health board, we have people like Helen, and then within the health board, obviously, we have our own employee wellbeing programs, and I know from working with partners that they have similar schemes, so employee assistance programs, and I guess it's up to us, isn't it, to increase the awareness of that and the need for that. So there's some brilliant reports out there that organisations can read. The Farmer and Stevenson report in Wellbeing in Work addresses the risk of suicide, and it talks a lot about kind of culture from the top down, so from the CEO talking in a way that's emotionally literate and being open and honest about mental health problems and mental wellbeing in senior leaders. So I suppose my answer is I think it's a systemic intervention, and there's certain amounts the health board can do, and it's largely consultative unless it's our own staff, and then we can advise others on what they might do, because there are certain professions that are just at higher risk, aren't there, because of the nature of their work. Train drivers is one of my colleagues treats lots of train drivers, but it's through their employee assistance programme. I hope that answers your question, Steve. Thank you.
Steve, have you got a supplementary?
Thank you. No, I don't know. Thanks a lot. Cheers. Thank you.
Thank you. Steve, do you want to tell us what you used to do? Would you mind doing that?
Yeah, I joined. I was doing my Duke of Edinburgh's Award, and it was the gold part and service, and I did Samaritans for about 10 years. So I was only supposed to do it. I had to do it for a year to get my qualification, but I carried on with it and was involved in training and things like that in Peterborough. Thank you for sharing that with us. Cheers.
Really important work. Thank you.
Right. So next up, we've got Dale. Sue, just a moment. So this is a difficult position now. So Sue is next. You're right. The trouble is Sue is not on this committee. So I could break the rules if everybody's happy, because then we've got Frances. Now, I technically should then bring in Frances, but Frances, I'm not sure if she's prepared to give way on this. I guess, I'm asking you to either make a decision for me or I'll make it myself. So
okay, I'll plump for my question then, Chair. 64% of the recorded suicides is from white ethnicity, but the rest is unrecorded. Why is that?
Yeah.
And surely, if as a proportion of the population, that ethnicity is their percentage would in their group be much higher. I'm just curious as to know why we don't record it, and is there any specific interventions that we could put in place for ethnic groups?
Yeah. This sounds like there's kind of two parts to your question. We were curious and a bit perturbed about that too. So I think some of it was around moving to a different recording system at the time. I think some of it is around, I think it will be addressed by anti-racist Wales action plans. I think some of it is around discomfort at that time of asking about ethnicity. And although that data was from 2021, So a few years ago, I think because of Anti-Racist Wales, I think that's already changing. So there's mandatory training around asking about ethnicity. And I think often people that have kind of white privilege feel uncomfortable asking about that, particularly if somebody isn't very clearly from a kind of minoritized ethnic group. So that's some stuff that we're addressing through kind of internal mandatory training, essentially. I think some of it was a system-based issue. And I think I invited, didn't I, questions around like, can you bring some scrutiny to that? So thank you for picking it up. There's a kind of odd scenario really with race and ethnicity. So in Newport in particular, is city of sanctuary, lots of asylum seekers and refugees, lots of people from ethnic minorities. We have got some specific interventions in that. So in particular, we have a psychological wellbeing practitioner who is multilingual, is from a kind of ethnic minority group themselves, and they work very differently. So following what would be good practice guidelines for increasing access for Black, Asian, minority ethnic groups, they embed themselves in the community, they use different language. We don't ask people to come to mental health settings because often that's stigmatised and people from minoritized groups won't go there. And we've seen an increased uptake in kind of well-being, if you like, services in that area. So is that data because if you're from a minoritized group, you're less likely to take your own life? Well, we don't know because we don't capture the data clearly enough. It would be unusual if that was the case, because what we know is if you're from a minoritized group, because of acculturation, stress, and all sorts of other factors that I could wax lyrical about, you're more likely to experience mental health difficulties, but they might not manifest in the way that we would recognise as mental health. So I wonder whether we're not capturing it because it's in physical health services and it's not captured in the same. So the ethnicity would be captured, but the mental health data isn't captured. So it's for us to look into, and thank you for spotting it. We're upstream of it, and I think it's improved already, but we keep getting better. Thank you. Great question. Did I answer both parts? I think that kind of why would it be that group?
Yeah.
Possibly, yeah.
First was why were you not
Yes.
recording and any specific interventions?
Yes, yeah. We'd like to do more in the way that PWP is doing because it's awesome, yeah.
Sorry, Sue, I'm going to let Francis go because if I let you go, people just say it's Sue and we're pals and we're on the same ward and I'm giving you, there will be that conspiracy theory that will start. So Francis, the floor is yours.
Thank you, Chair, and I would not have dreamed of making such a suggestion, but I'm very happy to go and I shall be quite brief because thank you very much for a very comprehensive presentation, and you've also answered, I think, all of the questions that have been put to you very ably. Francis Taylor, sorry, I wasn't here right at the beginning when people are introducing themselves, and I'm representing MEGA. My question is about what you talked about quite early on, about the dual diagnosis of both mental health and substance or active addiction. And I'm sure all of us perhaps have had some experience of people in that situation who then haven't been able to secure support which is appropriate to their needs because of this dual diagnosis issue. You mentioned that in Newport there's specific funding for a programme which is addressing that. Can I ask you, have you indicated also that Caerphilly have indicated that they're quite interested in supporting that? Can I ask you where you are, or where where we are in Monmouthshire? Is there, can I understand? Because certainly it is not unusual for people experiencing difficulties to turn to substances to manage, like you say, the discomfort, and I understand the point you make about it can be chicken and egg, and but it isn't unusual, is it at all? So I'm wondering, and I've certainly seen a really significant number of people who are struggling with mental health and perhaps then are turning to substances and maybe in active addiction. And to think that there isn't really, or certainly my experience is there isn't specifically, support available to them is a concern, a significant concern for me. Thank you.
Thanks. It's such an important area. I'll let Louise do some of the strategic stuff because she'll know much more about it than I will. Clinically, I guess there's a paradox, I think, in that there are services available across the spectrum of addiction and mental health. And I think there's something peculiar, and I mean that in a non-pejorative sense, around that population and the readiness to accept the intervention. And there's something about timing. There's a brilliant podcast I was listening to yesterday, but anyway, I can send that through separately, that is about ambivalence and catching someone when they're in that window of motivation and change, and that's about accessibility and awareness, isn't it? I think there's some interesting funding streams as well for drug and alcohol services. Some of them come through trauma, so specifically addressing kind of underlying post-traumatic symptoms and people using it in that sense. It will be interesting to see how it develops in terms of neurodiversity. Some people are using substances to manage the way that their brain works in society. You know, it's okay to be neurodiverse, but you're existing in a neurotypical world, so that can be really stressful. So I think clinically there are options, and it's a dilemma about how and when to get that to somebody at the right level, as you say. But I'll let Louise talk to some of the other points of your question. Thanks, Francis.
Thanks, Liz. Yeah, just to come in really, obviously under the remit of the Area Planning Board, so this is the planning board that looks at substance misuse issues. We have a number of subgroups under there, one of which is co-occurring. So this is where we work with all partners across Gwent, that's all local authorities, our public health colleagues, to look at how we can make sure that we have more of those seamless interfaces and that individuals don't fall between services. So this is quite a large part of how we deliver our remit around substance use services. And as I've said earlier, really, the strength of those partnerships and how we work together to look at how we have co-aligned agendas is really important moving forward, so that we've got the right kind of services and that we're interfacing with people at the right time, the times at which they're reaching out for that support. So obviously on a strategic level, those planning boards exist and our partners work alongside those. Some of the work that Liz has talked about in particular around COG and how that works in Newport, I know there are discussions across the board with our local authority partners on that, but from a strategic level, the Area Planning Board governs and delivers some of that work.
Francis, have you got a supplementary? Are you satisfied with those answers?
I was just wondering, Chair, and perhaps that it's not right for me to ask our very helpful attendees, but if Newport are funding a specific service, I was just wondering, are there moves for Monmouthshire or you mentioned Caerphilly or others to also fund? Because I think that is the issue. That's the issue you've absolutely nailed on the head, is when people are in the moment to accept support and assistance. What isn't helpful is to say, well, actually, we're going to refer you here or refer you there, and they have to wait, and then the moment's gone, and then and some of those people, you've talked about sort of people who aren't in active mental health services being at greater risk sometimes of suicide. I wonder whether that is the case in particular with some of that group as well, not being in the right place at the right time to accept an intervention where it's available. Thank you.
No, thanks, Francis. Hazel's laughing at me now because you just give me a sweet. We thought we were doing it on the quiet, and now I put a sweet in my mouth. I've been caught out. Anyway, so next on the we've got Sue. So we're now slipping into. So I can. What's he got now? So Jamie, I can see you there. Don't worry, I can see you've got your hand up again. I'm assuming you've got another supplementary. Please allow me to go through all the elected members, and I'll let you come in again. And I'm just mindful of the time, and I'm also mindful we've got guests at the back. They're sitting very patiently as well. So.
Sorry. Chair,
oh no, go on, Francis.
Can you hear me? Sorry, I was just going to say, would it be possible for consideration at the end of the discussion to consider whether we can write to the Cabinet member as a committee on that point?
Well, I think
maybe,
so. I think it's a really good point, and we can write to any cabinet member or anybody, in fact. So we can certainly give that consideration at the end of the meeting. Thank you.
Thank you. Thank you.
Are you going to stay to the end of the meeting, Francis?
I'm going to try, Chair, as it's you chairing.
Thank you. Right, so cheeky. Right, right. Let's throw me that compliment. So Sue's next up. Thanks.
Thank you, Chair. And again, I want to thank everybody because it's been really, really helpful. It's been fabulous. One of my two questions relates very similarly to Francis' question. What I want to ask is, and this relates to a history of working with Monmouthshire and Torvine and Newport youth offending teams. Mm-hmm. So what I want to ask is, if a city like Newport provide a service, does that mean that if Monmouthshire and perhaps others don't, that people will gravitate towards that need? And if that happens, and they go to Newport, do they ever get turned away due to a lack of connection and not get a service that they might desperately need? And can I just ask one more question, or shall I wait for the answer to that?
Oh, that would be lovely for my cognitive load. Can I do them one at a time? So I don't know. I could give you a theoretical answer. I mean, it's interesting that we're here to talk about suicide. The rate of suicide is lower in Newport, which is unusual for a city. So then you might ask, well, kind of what might explain that? I've always said it's complex. It's concentrated, isn't it, in a city? So there's good public transport links. It's easy to get to services. People have been known to just walk into, the hospitals, to walk into the community mental health teams, and we would never turn somebody away. We'd do our best to help, and so I wonder if the proximity is a factor. I think in the literature they talk about social drift anyway, so people who have got more difficulties. So in the olden days, we used to talk about there being a higher incidence of schizophrenia, for instance, in cities, and there was a social drift hypothesis that people would kind of navigate towards kind of city centres and urban areas. So I wonder. I think intuitively you're right in that people will drift that way if they have those needs. And I think because it's a Gwent-wide health board, we would see people and then try to navigate and signpost them and connect them to the right area. And so I think our interfaces between our different geographical areas are really good. So there's people like me who kind of hover above all of it, and we're really good at connecting up. So I think there's something in what you're saying. I hope we're as responsive as we can be, but I'm going to share your curiosity and have a look when we get back. You had a part two.
The other question, which is going to seem a little bit hard-based, but relates to also a history of working with domestic violence. You say 19% of people are perpetrators of domestic violence. Is that right?
Yes.
Can I be? This is perhaps very simple. Of the 19%, do people sometimes do it to punish partners? Or is it about their own mental health situation?
Yeah. The only way we can learn about that is from what they call a kind of psychological post-mortem. So locally, I don't have access to that information because that data was presented by the NHS executive, the kind of Welsh government group. So I haven't got the nuance to that data. I've had a look into the male violence strategy. I think Jenny was part of meeting with the people who are leading that. And so I think reading some kind of first-hand accounts, I think both things can be true. I think there's multiple truths here. So I think on occasion it is around, those tragic incidents where, somebody has taken extreme action against a partner and then they can't live with themselves and they take their own lives. And sometimes they do it in that slightly, and this is a really clinical issue, but essentially they describe the kind of distorted state of mind that you're in when you take your own life, and your thinking becomes really quite warped. And so I can imagine that in that situation, someone would think, oh, well, this will show them as if death is not permanent, and as if they're going to live to see the impact of their actions. Yeah. So I think it's really complex, Sue. I think it doesn't sound like a hard question at all. I think it's a difficult area to reach into, isn't it? And there's lots of people affected by domestic violence. So I'm pleased you asked.
Thank you. Thank you, Sue. Jackie.
I'm sorry, Armand, I'm a bit affected by Sue's last question, so bear with me a minute. I just want to follow on from Sue's. I'm quite interested in we sat through a presentation 2 weeks ago, Live Fear Free.
Yeah.
And 2 women die at the hands of men every week. But also they're starting to collect stats around suicide, women that actually take their lives because of abuse. I know from sort of family experience, my brother-in-law took his own life because he couldn't face up to what he'd done. Mm. So I'm just a bit offended by Sue at the minute. But the other thing that I also wanted to ask was, I'm quite interested in the stats about older people and the fact that, that seems to be quite a, sort of a big sort of chunky cohort as well. I'm trying to understand that in the context of assisted suicide. Yeah. And I know that in Monmouthshire we've had a couple, in my time as a social worker, we've had a couple of families that, because the carer couldn't cope anymore, and then they both died. So it's just a really difficult subject, and I'm sorry I'm a bit emotional, but I just need to take a bit of time out. But I just wanted to ask that, sorry.
No, that's sorry. Jackie, we're sorry this is distressing you, but of course this is how real this committee can be, and we're asking some really clear, poignant questions which all the community deal with, all the professionals here deal with.
But it's 35 years ago. It's not like it was yesterday. And I was interested to hear about the support for bereaved families, because it was nothing for us.
No.
It's still there.
Yeah.
It's still there. So I'm sorry. I just didn't really want to say that, but this is kind of life, really, isn't it?
No, thank you. And this committee's for everybody on this local authority and for the members of the public. So thank you for sharing that with us, Jackie. Thank you very much.
I'm so glad you shared that, Jackie, and I'm just really admiring of the fact that you've sat through all of this when you've got your own lived experience, so thank you. And I always say to people, please don't apologise for your distress. It's the most normal thing to feel in the context, so thank you. I feel privileged that you have shared it with us. I think really I just wanted to honour your lived experience. I'm not sure what I can speak to as part of it, other than to say, I'm sad that help wasn't available, and it is now, and that's encouraging that there is help available now. I think that domestic violence is as complex as suicide is. It's incredibly complex, isn't it? And the earlier we can detect it and see that there are needs in all parties, and in particular, I was thinking about Jill's first question, children and young people that will be in the midst of that as well, and recognising that it affects a whole community of people, the better. So I'm really pleased that there's more focus on that. And you said you were interested in older adults as well. And I don't think suicide is any less impactful when it occurs later in life. It still has the same veil of shame around it. It still has the same veil of complex grief around it. The factors that they've identified underpinning suicide in older adults are slightly different. They're often related to a kind of spiritual belief. They're often related to chronic pain or to physicality, kind of physical frailty or lack of physical ability, and a sense of loss around that. And there's other people here that will talk about older adult mental health services. I'm definitely not an expert on that. It's right to be curious about it, and to, again, as much as it takes a village to raise a child, also takes a village, because of our care arrangements these days, isn't it? The culture around caring for older people. Some beautiful initiatives around intergenerational work that schools do with older people's homes and residential settings, which are, again, lots for us to learn. Anyway, it's for another time, but I just wanted to say thank you, and for bringing your lived experience to make sure we keep it human.
Thanks, Jackie. Liz, thank you. Jackie, are you satisfied with that response?
Yeah, thanks, Simon. Yeah, thanks.
You're always.
I just want to keep it, sort of relevant, and I agree. I mean, we've got a fantastic new. I'll give a plug to Sevenview Park Care Home, because that's just up the road from us, and it's fantastic. And to see community groups come in and do music sessions and sort of local primary schools and stuff as well, it's great. So yeah.
Jackie, are you going to, just a question, because I mean, with your knowledge and your passion for this issue, and you are the Older Persons Champion, I still believe you are, aren't you? Are you going to stay for the latter part of the meeting?
Yeah, I try to. I need to just take 5 minutes, but I'll come back after.
By all means, take 5 minutes, have a cup of tea, take the dog for a walk, whatever you need to do. Jamie, thank you for your patience there.
No, thank you, Jackie. Very moving, and I hope just take some time for yourself. Yeah. Just a quick question, really. Seems we all, I think, agree that prevention is better than reflection, especially around suicide. A number of years ago, up until the pandemic, Mind in Gwent were able to refer directly into the CMHT, into the community mental health teams. And when we had concerns, again, as I said, we see people once a week, twice a week, every single week for a number of years. So we get to understand when somebody is falling and slipping into crisis or feeling unwell. And up until the pandemic, we were able to refer directly into the community mental health team. Post-pandemic, that doesn't happen anymore, and I feel that there are barriers being placed between services and clients or patients and individuals. For example, now, if somebody that we are working with presents as becoming unwell, even potentially in psychosis, we have to encourage them to go to the GP. We would take them to the GP. The GP does an assessment, and then they do a referral. The referral then goes to the community mental health team, who then either look at an MDT, and then either come, in our experience, predominantly comes back, even without a conversation, they come back and say, this isn't for us, this is for primary mental health. So then we have to start that process again, or they get signposted to 101 option 2, which then normally what happens is they say, could you present to either your GP or the hospital? And all these are layer upon layer of and barrier after barrier, and that's a major concern for us. And I just wondered, are there any plans of reconsidering the referral pathways?
Yeah, that's really important. Thank you for highlighting it. I think there's sounds like there's a degree of variation there as well. So I'm closely connected to the CMHDs, and I don't recognise that. So thank you for highlighting it. I think we'll take it back if that's okay and have a look into it. We're reviewing our models of care at the moment, which would include referral pathways, and obviously there's a move towards a kind of more accessible services. A 111 press 2 being the start of that. So if it's okay, I don't mean to be evasive, if you can leave it with us, I'm grateful for it being highlighted, and we'll have a look into it. Thanks, really appreciate it.
Thank you both. Jamie, that's an excellent question. I'm going to say at this point, we really should have, I mean, we're running out of time. It's a shame that we couldn't have given this debate between the two of you, because you're at effectively the front line, really, I guess, as much as anybody else, and we genuinely appreciate the work that you do across the community. We always look for outcomes. So I'm sorry to corner my colleagues there, Liz and Louise, but effectively we always try to look for outcomes. We managed to pull this off before, so we're going to invite you all back in probably 6 to 9 months and ask to see whether or not there's been any outcomes of this consideration given, because I think Jamie's made an excellent point, really, and the committee, I'm sure, all share the same concerns as well. If you're seeing it, then it needs to have proper consideration. Are you satisfied with that, Jamie? Do you mind coming back and sitting for 2 hours waiting to, for your question to pop up?
Certainly, Chair, that'd be no problem at all.
Excellent. All right, thank you. It gets to the exciting point now where I've got my question at the end of it, so thank you all for being patient.
Sorry, I think Councillor Bond's got...
Oh, Councillor Bond, you've got... Of course, Councillor Bond. This meeting wouldn't be the same unless Councillor Bond had a question. Councillor Bond.
No, Chair, Megan, I think another person from Mind would like to share something as well. Could we ask her quickly to input?
Yeah, sorry, I didn't see Megan's hand up, Megan. I do apologise.
Oh, no, it's okay. I popped in the chat earlier that I could offer some feedback from clients that we've had about the barriers when they're feeling suicidal to getting help. So if it's okay, I can share some of those.
Yes, by all means.
So the biggest one we've already spoken about is the issue of going to mental health services, them saying that they can't support them while they're on substances, and then going to get help with substances, and them saying, we can't help you because that substance is what's keeping you alive at the moment because of your suicidal thoughts. So that's one of the major ones that we're facing. There's also issues with the appropriateness of treatment. So we've had people present at mental health services saying that they're feeling suicidal and are put on group DBT or group CBT sessions, which works brilliantly for a lot of people, but for some people it actually re-traumatises them because they're hearing other people's stories, they're coming off them and feeding back to us that they are actually in a worse state of mind now because they have listened to however many people's stories on that call and feel like they can't share them themselves. But then if they say that, they're scared that they're going to then be shut off services because they're declining treatment, if you get what I mean. They also have some issues with people that don't necessarily like taking medication. That's the same concern that they have, is that they're going to go there, people are going to try and give them medication, they say no, and again they're scared that they're going to be shut off from services. So I think a lot more communication might be good in that sense. There's also an issue with waiting times as well, so people are put on waiting list for trauma therapy, which can take up to 2 years, which is understandable, but in the meantime they're not offered a lot in that space. And we've actually had people go to trauma therapy and then they've been told that they are not eligible for the trauma therapy after 2 years because they're not able to cope with the emotion that trauma therapy is going to bring up, which then has led people to think, well, what's the point in reaching out in the first place? So I think maybe some communication with the client about what to expect from the service might be good as well.
Yeah, should I? I mean, I just want to receive that. I don't think there's a question. I think I'm going to receive it as feedback, which I think is really helpful because you're honouring and representing people's lived experience. And, services can set the best of intentions and still, there are times when we won't meet everybody's needs, and it's really important that we listen and learn from that. So I just want to receive it. I think if it's helpful to have some assurance, hopefully there's some assurance in what we've said today about the intentions and the culture and what we are aiming to achieve, but really mindful of time. But I'm really happy for you to make contact, because lots of the things that you've talked about there would be things that would actually be directly in my portfolio, so the delivery of therapy and waiting times and those sorts of things. So I'm really happy. Is that appropriate, Chair, or is it better to speak to it? I'm just really mindful of the time, but also just want to thank you, Megan, because it's really important that we bring the lived experience voice, and it's not unfamiliar. Having made a brave decision to go and talk about your distress, including traumatic life experiences, and then to know you have to wait, always hurts my heart more than is sometimes manageable. So we are doing all we can, and we still need to do more.
Thanks, Liz. Thank you, Megan, for that. And that's just not sometimes you get on a committee of patronising, thank you very much, and off you go. This is why I'm going to invite you back again, you and your colleague, really, because this is what we're going to hold our colleagues in a friendly way to account, because that's what we do. And you're more than welcome, I should say, to come back in 6 months and ask them what they've done about it, really. So that's it. Liz, thank you for that.
It's a genuine offer to make contact, Megan, because we can work, the intention is to work in partnership, so please do make contact. I know Helen, our trauma pathway lead, would be really keen to work with you. She's doing lots of work with new pathways. So, please be in touch.
Okay, thank you both. My question, right, so I waited patiently myself, is, so again, it's already been touched on really, so the Monmouthshire data this is the last data that we have on it's for 21 to 23. Now, obviously the world was a slightly different place then than it is now post-COVID, but it says that Monmouthshire has the highest rate of suicide in Gwent. And I'm perplexed by that. We talked about some of the resources that you have in Newport and the responses that you have, and not say facilities, but access. Is this down to I mean, I'm just kind of guessing it. Is it down to reality? Is it down to post-pandemic behaviour? Is there something unique about Monmouthshire? Or is it that the cost of living is so disproportionately high in Monmouthshire? And I'm not trying to lead you, but it's a question that I have, along with Sue, looking after a ward that has significant deprivation, is the Fly and Start scheme there. Is it because the cost of living, which incorporates then the cost of either renting or buying in an area which is a predominantly working class area, is so disproportionately high that effectively people can no longer afford to live and are overwhelmed in the same way that we've talked about the rurality, the pockets of deprivation? Those people are overwhelmed by their inability to support their own families and themselves.
I was just going to have a quick look at the raw data. I probably haven't got time to do that. I think it's multifactorial. So there's 24 deaths in that period. That wasn't replicated when we looked at it for 2024. I find it really hard not to look at you when I'm talking to you.
It's all right, no, it's fine.
I'm going to turn my back this way. So it wasn't replicated in 2024. So was it an anomaly? Was it something around how COVID in particular affected people in Monmouthshire? Okay. I think it is, my memory of the data, and I won't check now, but happy to talk about it another time, is that it would be multifactorial, and actually there wasn't a clinical trend or a social or demographic trend within those 24 people. They were quite different from one another. So my memory is that there was a couple of young people with particularly severe psychotic episodes. That was a couple of them. There was a couple which were entrenched kind of neurodiversity with significant functional impairment. And I guess that's, the invitation is for all of us to be thinking, what do our communities do, in particular for neurodiversity, which I think is going to be a growing clinical trend. So I'm sorry I can't answer it specifically. I think it is, we're all wondering together.
No, I didn't want to lead you, and you've given me an answer, and that's fair enough. Some of my next questions, because we are running out of time, and I want to sneak in a comfort break because I need one, is that, I'm sure we all do, and I am sorry to you at the back, because I think you probably thought we'll be out by 12, didn't you? But we're making a day of it today. I'm joking, we're not going to make a day of it today. Is that dealing with families of, and I see this a lot online, so the pushback of family courts and the consequences of family courts. As you know, there's a delay still in family courts. It's horrific in Wales. Is there any statistical evidence to suggest that any of the kind of issues to do with side, or the conversations where you deal with it up front, you get people come to you that have lost contact with their children, or temporarily lost contact with their children, or through separation, the anxiety that comes from that, or the children themselves factor into what you do? Because I mean, I won't get into the war of family courts, right, and everything that goes around that, because that's too big an issue for this committee and would be dangerous to do so. But is that a factor, do you think?
I mean, again, multifactorial. That's such a political answer, isn't it? And if you have a look at the ENCISH website and the RTSSS, they do talk about domestic kind of, forgive the term, dysfunction as a factor in some of the deaths by suicide. So that might be domestic violence, it might be family courts, it can be men on the edge of being prosecuted around illicit images, indecent images. So locally, there isn't enough of a trend for it to have stood out for us. But obviously, the base rate, very fortunately, the number of people who die by suicide is low. Fortunately, I think it's really important for all of us to remember that. There's enough good work that it's still very low. And so you can't make meaningful interpretation of the data. But Manchester, because they've got a much bigger data set than we have just in Gwent, and the RTSSS, and you've got the report attached to our presentation today, they will make more sense of that.
Lovely.
So, sorry, inviting you to have a read.
No, it's fine. Thank you. Listen, this has been a fantastic meeting, and I'm sorry it's been so long. In a way, it's a shame that we can't do it. It's in two parts or whatever. But you've come along. You didn't have to come along. You were our guests, and you've You've given us an excellent presentation. We've had some great questions, and we've had some excellent answers. And so thank you for that. I'm going to say, on behalf of the committee, we really appreciate the work that you do, and we're thankful that you came along today, and you're now free to go. And of course, to remind you, we hopefully, because we've been so nice to you, you'd come back in 6 months and bring it. Cheers. Right. Thank you all. So this part of the meeting is now. Thank you. So this part of the meeting, we have a comfort break in 5? Yeah. So 5, and then our colleagues at the back will come down. So anybody that wants to stay is welcome. And again, the revolving issue of any members that want to ask questions, you'll have to just wait for the committee members to ask questions, and then you can come in for that latter part. And Jamie, you're more than welcome to stay as well, all of you. Thank you. But you don't have to. Quite detailed. sporadically. We haven't got another meeting until October, I believe. Although that might change if Hazel has her way. Okay, thank you, everybody. Is everybody back in the meeting? I can see, let's have a look here. So we've got Malcolm's with us, we've got Steve's back with us, Jill's back with us, and John. Hi, John. And then who else? Anyway, let's crack on, yeah? So next on the agenda, we've got care for people in the community with dementia, including support available to families. So we've invited an Aaron Bevan University Health Board to outline how it delivers their services across Monmouthshire. So we have, obviously we've got Amanda Went, and have I said that correctly? Went? And Jennifer Winslade. So Amanda's the lead nurse of dementia, and then we've got the Jennifer, who's the executive nursing director of nursing even. So we're going to. I'm just warning the committee, and I say that in a friendly kind of way, that we need to be out of here within an hour. If there are any outstanding issues, we can leave it for another time because they've offered to come back again. It's just that the way that the meeting, which was the bit of the meeting before, was just taken up a lot of time. So, without further ado, I'm going to leave the floor to our colleagues here.
Okay, lovely. Well, thank you very much. As I was introduced, my name is Amanda Went, and I'm the lead nurse for dementia for ABUHB. So we were asked, and I'm very happy to attend today to give you an overview. At least this is how I've approached it. So very happy to take questions later or provide any additional information that I may not have covered for today. So annually we're asked to produce a report to say how well we are doing or where our gaps in services and what the challenges are around dementia care for Gwent. So this year's annual report is the one that we've shared with you prior to the meeting, and I'm going to go briefly through the slides today. So the annual report is around the All Wales Dementia Action Plan, which hopefully is familiar to most of your members, but also the All Wales Dementia Pathways of Care, which was introduced in 2022 and produced from people living with dementia and carers to advise us what the standards that they expect us to be delivering against. So in Gwent, we mirror the national All Wales dementia structure. So my next slide gives you an understanding of how we develop the services and improvements in care. And we divide our services up into 5 work streams. So work stream 1 is around our engagement opportunities. Work stream 2 is around memory assessment and mental health and LD services and dementia care mapping. There's a part B in workstream 2 where we ask carers to advise us around their pathway and develop the education plan and expert patient programme. Workstream 3 is around the dementia connector role. Workstream 4 is the dementia hospital friendly charter, and the charter includes care homes and prison services where we've got healthcare needs. Workstream 5 is around learning and development, and then part B is around measurements, how we're doing and how our performance targets are. So in the next couple of slides I'm going to be able to give you a little bit of information about each one of those work streams. So work stream 1, so the national work stream set us a target of developing a citizens engagement model. Initially, we were asked to look at our area needs assessment, and it was identified that Newport would be our first area where we would develop this programme. So the listening campaign asked us to engage with our population, identify where our needs are, what the scoping needed to be, and we did this through a series of number of resources. So we did some podcasts, webinars, different events. We went into the colleges and the schools. We looked at community engagement events that was taking place within our region, and we've since developed that across Gwent. So last year, for example, we did 36 individual events and attended numerous community engagement opportunities. So in addition to that, we were able to scope out and develop hubs within each one of our boroughs, and the Dementia Hub specifically focused on engaging the people within that community so that we could bespoke the services around those area needs. We engaged with our dementia-friendly communities, which have been in existence for many years, and we developed that further. So currently there's over 200 participants in the Gwent-wide dementia-friendly communities. And again, the work stream within that focuses on some intergenerational work, as well as supporting our businesses, our communities, our prisons, our care homes, and obviously members of the public. So essentially, we attend anything that we're offered to promote and raise awareness around dementia. We also developed a dedicated email address so people could contact us with feedback, information, but also importantly asked us for help in signposting and reaching areas. There was a specific focus, as you'd expect, to a multinational, multicultural area, Gwent, so we wanted to focus on those areas that may be more difficult to engage with. We held a regional dementia conference, and unlike many conferences, this was not an academic conference. This was an opportunity to share and showcase some of the work that's already going on, but essentially the work that can continue and encourage people to be part of that conversation. So I appreciate this is a whistle-stop tour, but we'll get through this and then we'll take some questions specifically around it. I just wanted to offer you that overview. So workstream 2, it was around the memory assessment pathways. So this is our opportunity to review our current pathways, again identify what we were doing well, but importantly where the gaps were. National data sets were introduced, so we've got 10 data sets, and we benchmark against all of Wales to see how we're developing those services. Those data sets are specifically around pre-screening, diagnosis and ongoing support. Workstream 2B there was around the carers education, so absolutely recognising the essential work that we need to develop around dementia-specific carer education, awareness as well as skills and support, ongoing support. So recognising some of the challenges that this specific set of carers, where they tell us that things like having respite services is absolutely paramount to some of their needs. So in response to some of that feedback, a carers education and support programme was set in place, and they now run 6 weekly in each one of our boroughs, and they cover things like legal aspect, financial support, ongoing social and physical support, and there's a leaflet embedded within this presentation that gives you more information on how to contact those. So that's probably one of our biggest achievements in terms of carer support as part of Workstream 2. The Workstream 3 was around the dementia connector role. So what people told us was that once they have a diagnosis, that they absolutely need the support for ongoing and continued involvement, so signposting, access to services. So the Dementia Connector role was introduced and is now part of the memory assessment pathway. So from the point of diagnosis right the way through to end of life, there's an opportunity to have access to, and where possible, the same person. That's a huge ask when we know the turnover of some of our services and people working within them. But the aim is that there is a consistent point of contact throughout somebody's journey of their illness. So Workstream 4 focused on our dementia-friendly hospital charter. So this charter was developed, as I say, for people living with dementia and their carers, and they said this is a really challenging, scary, horrible time when somebody needs to go into hospital, especially if that stay is around an urgent care assessment. So the Charter outlined some of the things that they wanted us as ABUHB to commit to, and obviously our executive board were very happy to sign up to this. And as a consequence, there was this whole series and a 3-year plan that followed our improvements in dementia care. As I mentioned earlier, this focus on our our healthcare units within prisons and our care home sectors as well. So we developed an animation. So the animation was shared through all our media channels, including our dementia-friendly communities. And again, it outlines what the expectation is, the expectations from carers, patients, as well as hospital staff. We need to understand the commitment that we're giving to people. There were several things that I wanted to share with you here, but it's not exhausting some of the examples of the work within the Workstream 4. So we take a really strong lead from our feedback. So engaging, taking our feedback, learning from where things haven't gone maybe as well as we'd expect, but importantly where we've been commended for the work. So we're sharing best practice as well as improving those care. So in your presentation slide, you will see some of the examples of those. I'm just going to mention one or two. So the Meaningful Engagement Programme is a programme that was developed because we know people with dementia struggle with the environment, struggle with the routine and the structure of hospital care. And the feedback is very much that although we need to meet a clinical need, there's also about a well-being and supportive psychosocial model that we need to maintain within our hospital. So engaging people in a structured, stimulating environment, offering activities or engagement that is person-centred and specific to their individual needs was really important. So that was an opportunity to work with our NHS Charities Together grant, and that programme is in operation at the moment for a period of 18 months. Due to finish in October, and the learning from and the actions from that programme have been absolutely incredible. So we have, in response to that, developed specific roles within ABUHB. So activity coordinators now are employed as members of that team to engage with and respond to individuals' needs. We did a series of what they call VIPs. So VIPs doesn't stand for anything in terms of, it's around the philosophy. So the philosophy of the VIPs improvement plan was valuing and promoting the rights of the person, identifying an individual's needs, looking at care from a perspective of the carer, patient, as well as the staff, and looking at the psychosocial, environmental opportunities that we've got within our current structures and hospital bases. So we then produced a 1-year-on report showing where works has taken place and where it's worked really well, but also acknowledging where some of our challenges are and how we can embed that and showcase and turn that really useful information into themes and produce that back to our executive of patient quality and services, as well as our regional investment teams as linked to the RPB regional partners. And again, some of this work is already in your presentation, so I'll take the opportunity to review that if you haven't already done so. So as you'd expect, the dementia work is embedded within the Health Board's priorities and linked very closely with work such as the Enhanced Care Review and the Best Placed Care programmes. In order to deliver on these huge expectations, we developed a Dementia Champions programme, and we invited one person from every department and ward within each care home, prison and hospital to become a dementia champion, with the aim of sharing, cascading, taking feedback from those ward areas back into our area action plan. We introduced bedside boards, so people told us that sometimes in a really busy environment, having information at a glance at somebody's bedside really helped them to be recognised as individuals. So this isn't about clinical care, this was about what's important to me and what will make my stay more manageable while I'm with you. We relaunched John's campaign. So John's campaign is the right of carers to be involved, very much embedded in our philosophy, but this was more about advising carers about their rights and their expectations, that it's not a handover when somebody that you care for comes into hospital. You are very welcome, and actually it's promoted that you remain involved with that person's care. And that might be visiting out of hours, it might be staying overnight, it might be just being briefed on a regular basis if you're deciding that that's a period of respite for you while the person you're caring for is in hospital. So we obviously promote the intergenerational work. It's valued in terms of the importance it is for sharing dementia practice with our younger generations, but also the benefits of intergenerational has on people's well-being whilst in hospital. We co-worked with some of our specialists within the health board, where we recognise the correlation between inpatient falls, nutrition, hydration, and general well-being, depression, isolation was a huge factor. So one of the initiatives was around developing a Stumble by Crumble book. So this book was then developed alongside one of the primary schools and then shared as part of the intergenerational work, and is now available in all libraries and each one of the schools, primary schools across Gwent. Our specialist occupational therapy team developed an activity programme. So this was about re-ablement. It was how do we keep people as well as they can whilst they're in hospital and at home, and helps with transition between admission into hospital, during hospital, and obviously facilitating discharge. There were numerous priorities that we've identified as workstream 4, as with each one of the other work streams, and some of those are outlined in the presentation. So workstream 5 was around learning and development. So this is where we aimed, again, at a national level. The Good Work Framework guides us in this, and understanding what it's like to receive care, how care needs to be compassionate and competent and wise, and it needs to be developed in 3 levels. Informed, so dementia awareness; a skilled level, so when you're actively involved with somebody's care; and at an influencer level. And I guess the annual report helps us to achieve that by raising awareness and understanding, and asking people to take these findings back to your area, and how can we further influence dementia care in the area or scope of work that you're involved with. So our aim is to recruit and to deliver capable, competent and confident staff to be able to deliver dementia care in all sectors of our work. So again, the learning development is an ambition that all social care, third sector, carers and patients are invited to be part of that learning and development. And we take seriously and actively engage, looking for patient stories, patients' experiences to be embedded within that learning. Okay. So there are some stats involved in the next slide, which tells you some of the examples of the work that we've progressed. So by using specialists within our organisations and departments, we've been able to develop a series of bite-sized, so short interactive sessions that can be delivered face-to-face or online. Video recorders recordings so that they can be shared at opportunistic moments. And they're specifically around things like oral care by our dental community teams, hydration and nutrition hydration, pain management, our Mental Capacity Act. So they're numerous. We also took an opportunity where we previously would have delivered and recruited in, commissioned in external training opportunities, such as the Dementia Experience Bus, which is significant cost to us as a health board, but also to our partners within social care. And we've now developed our own training programme under this work stream, and we are delivering this at least 4 times a year currently, capacity allowing. We know the importance of anticipatory loss, so not having a diagnosis is a life-changing condition. Hearing that and the adjustments that's needed to be made is huge. So a series of work took place with people that have gone through that process, and they gave us information that we've now turned into a training opportunity with video clips illustrating some of these challenges, especially for those around younger adults with diagnosis. So the impact on education, about childcare, financial loss in terms of job and security was recognised as a huge challenge. So these are some of the things, again, that we were looking to take forward, and working alongside our existing dementia friends, we're looking to not just further developing, but people are saying to us that the original Dementia Friends session, which is an excellent resource that was produced by the Alzheimer's Society, wasn't really enough now. It's really refreshing to hear that people are saying, we want more information. How do we get this information? So a Dementia Plus a commission package has been introduced, and we are currently going through a train-the-trainer model to maximise the impact that that's going to have against across our population. And how do we know how we're doing? So Workstream 5B was around our monitoring and measurement. So there's a series of review data sets, our national audit of dementia, our memory assessment pathways. Our LICE colleagues have recently completed a survey where we've received their guidance and their notes, which we will embed in part of our learning, as well as our action plans and internal audit processes. So this is how we know objectively, but subjectively we know from the patient feedback that we received. So in the health board we've got a Civica patient survey system, and we ask our colleagues within those teams to theme the responses that they've had, and we use those themes to measure how we're doing and inform our future plans. Okay, these are in the slide you'll see some of the work that we're specifically focusing on, and the most recent I suppose high on the agenda is the hospital dementia hubs, where carers and support is being developed, and then each one of our region has the dementia community hubs, so which are multi-agency opportunity for people to drop in and ask questions, and then we can signpost people to the appropriate service in a timely and appropriate manner. Okay, so I apologise, whistle-stop tour, I know, but the conclusion is that Gwent-wide plan is around improving and around continuity and consistency, and that's what we aim to do. I'll offer you in a moment some specific information around Monmouthshire. Obviously the scrutiny is around the Monmouthshire borough, but essentially we want that consistent approach across all of Gwent, so it shouldn't be about a postcode lottery. It should be wherever you live in Gwent, ideally wherever you live in Wales, but we'll focus on the areas that we've got some ability to influence. And there's a lot to do, but there's an incredible amount of work that's taking place, and probably this presentation wouldn't do the amount of work that's happening justice. So that's my whistle-stop tour. Jenny, is there anything you wanted to add to that?
All right, thank you. It's very interesting. Thank you very much. Of course, most of us read most of the pack. And also then I would recommend, just in case anybody skipped through it, which to be honest with you, I did, I have to be honest with you, this other document at the end, Orwell's Dementia Care, the more you read it, the more interesting it becomes. We've got questions. I think first of all, Jill's got a question. I can see a hand up. And then we've got Dale.
Yes, Chair, thank you very much, and thank you very much for the presentation and all the good work that you've showcased in that presentation. Thank you so much for everything you're doing. So I've got 3 areas of questions, please. One was about Monmouthshire specific, which you just alluded to. For example, the Dementia Champions, where are they? Who are they? Where are they? How do we get in contact with them? How do people access those people? So all about Monmouthshire, and particularly, where's the funding for this coming from, and is it sufficient? You said 16 care homes, that's, I guess, is including Monmouthshire. So really about, you said it's widespread, but specifically Monmouthshire. The second question, please, is around performance. You report to bodies, as you've suggested in your report, that, is there anything in 2025, because I can see a lot of that information was targets for 2025, but no specific smart targets, as in we'll do this by this, or we'll do wonderful targets and obviously the right things to do, but is there any way we can have some progress to date, because that's a little bit old, isn't it? And you, for example, the monitoring performer, which is something you were intending to do, so to evidence and get a standard response. And the third question, please, is around mitigation to reduce the speed of onset. I don't know whether it's part of the scope of this, but and what about prevention? Should we be changing our diets? Do we get advice? As in what the things we shouldn't be doing, more exercise, more whatever. I can see that it's in there about helping people to reduce the chance of falls because of doing exercise, but how about before that? I guess that's not within your scope. Thank you.
Okay, lovely, thank you very much. Absolutely, and it's always difficult to decide what to put into an annual report, because each report builds on the previous year's work. So, but first, if I take your Dementia Champion, so we have a register of dementia champions, and currently it's something like, because it changes, but there's 286 at the last count, people that are on that dementia champion register. And the champion register is one that's held by the dementia team as part of the patient experience and involvement team. And we collect who the person is on our ward, what area they or ward or department or services. As you said, this is much wider than the hospital. And from that, we record the departments of the area, so we try and ensure that we've got representation from each speciality and sector within that. And the database provides us with an opportunity as a distribution list. So whenever we've got further information, if we need information, if we're looking at people's experiences, it's an opportunity for them to reach into us to showcase some of the work that they're doing, and obviously to identify the gaps and where we then can consider what's needed. So that's it's a two-way process. We send information out and receive information from that. We also invite our dementia champions to be part of our learning and development groups, so where we can say how do we make those improvements, how do we include that in our VIPs, our virtual ward team improvement programs. And I mentioned earlier on an example of that was our prison services, where we've got Usk and Prescoed. and they are currently undertaking a series of improvements by identifying who their champion is and working with our team, coming up with individual action plans that are bespoke to their area, and then they're supported by us as a team to deliver on those. And then that feedback in turn then comes back into our programme and influences our actions and priorities for the next coming year. Even though we'd have a 3-year plan, obviously that plan is reviewed and evaluated as we're going on to check our priorities are consistent. Did I answer your first question, Jo?
Well, really, it was about where they are and have we got any in Monmouthshire, really. But you've asked about, they've very, very well answered what the need is and how they work. It's wonderful, but just how many in Monmouthshire. So really, the first question is around Monmouthshire specific activity coordinators, care homes, the work, the involvement. Is it the champions, the dementia hubs, everything that has been stated? How are we served in Monmouthshire, please, specifically?
Absolutely, yeah, no, absolutely understand that. The answer is that I've got all these pieces of information in different databases, but I would be very happy to pull that information. I guess a little bit of learning from me. This is the first time I've attended Scrutiny, so I wanted to offer an overview. I'm very happy to produce a paper specifically to Monmouthshire that outlines all of those individual things around the care homes, where we're including the specific, which care homes are included in, for example, the dementia engagement programme, and the outcomes of some of that as well.
The schools and whatever. Brilliant, thank you very much. Understand overview is needed, but also some specifics, please. Thank you.
Absolutely. The second one was around the how do we get this message out there? So we have a ABUHB dementia web pages, which is internal and external, so people can put ABUHB and go direct to our web pages, and there's a significant amount of resources around each one of the presentation titles that I've just shared with you, but also what other areas and what other partners are doing around dementia care. That also is dovetailed into a Padlet, so the Padlet shares up and coming events, information that is topical and related to some of the information that's shared with us by our partners. So again, I wanted to emphasise, I suppose, that this is very much a regional model and in partnership. It's a collaborative approach. So when I said earlier about getting some of that data, it's because dementia-friendly communities is part of the regional partnership board, so they will have a database of the dementia champions that maybe are within local businesses or the intergenerational part of some of the schools. So it's about collating that information from each one of those partners and producing that into a format that would be really helpful for you. So the Padlet and the dementia web pages is important, and also the dedicated email address. So again, creating an opportunity and even as simple as the messaging, subliminal messaging around there. We've had pens with our email address on there with scrollers to say, this is what we're aiming to do, these are our objectives, drop us a line, tell us how we're doing, tell us what's important to you, tell us where we've done things well or where we haven't achieved our targets. So we use that as our one of our points of contacts to gain feedback from the citizens around that care.
Thank you. Thank you. Sorry, did I cut you off there?
No, it's fine. No, I'm just thinking, like, the KPIs.
You're on a roll. I can see you're on a roll now, aren't you?
I'm on a roll.
It's flowing out.
We could stay for another hour.
Well, what I was going to suggest is, sorry to intervene, is that because we're not giving you, I don't think we've given you enough time, and this is your first experience, and this is an ongoing piece of work. This will be, for the next couple of years until the end of this. So we're going to, not only would we want to ask you again, at some point we'd like to come and visit you and see what you're doing, if that's okay. Obviously, we want you to invite us. We can't just rock up and just, gate crash. But this committee has the brief to, go out and do stuff, although we haven't really. But we can all, as long as you invite us, you can show us what you're doing. Because I think, as someone who's been on as a reciprocant, user, or as a carer myself, I think it's worth every councillor seeing what you guys do for themselves. But anyway, we've got another question, which is Councillor Rourke. Sorry.
Questions that I asked.
Yeah, sorry.
Yeah, I'm conscious I have hands.
The performer and also mitigation advice and whatever is with that. Would we find that elsewhere? Is that within your scope?
It very, very much is, and I'll keep this as brief and take the opportunity to share with you and the committee members some of the KPIs or the key performance indicators that we're using. So again, echoing the national model, so we are using that for benchmarking, but there is a data set for each one of those work streams to identify how we're developing, how we're performing against each one of those. So again, that's a presentation in itself. I'm very happy to put that together for you and share that. Prevention and mitigation is a huge issue for us, and one of our, not just us, but our Public Health Wales and the Older Persons Commissioner in her recent report highlighted the need for us to be working on a preventative model. So in one of the slides I would have briefly shared with you that there are 12 factors that we're working on, and that's including, cholesterol. What's good for the head is good for the heart, essentially, but understanding more trauma-based implication of sports and the implications of sports on prevention and what the work that we can do. So an example of that is we work really closely with the Gwent Dragons and the schools around awareness and education and influencing their plans for us. For some of that, I'm aware I waffle through that because I'm mindful of time. But again, there is a huge amount of work going. We need to be focusing on not just prevention of the disease, but also how we recognise earlier what the signs and symptoms and how we can intervene with medications we know can slow down the progression of dementia, but also how we can intervene more early in terms of the pathway and enable people to live as well as possible for as long as possible within their own environments.
Of course. Thank you. Yes. Yeah, go on.
Just to add something very briefly, of course, we recognise that this isn't just about hospital care or secondary care. Actually, this is about working in partnership with our primary care colleagues. It's in partnership with voluntary sector. So the place-based element of this is really, really important. So in working with our public health colleagues in the local area, that's how we'll start to tackle some of the prevention, the messaging and the early intervention, and we work very closely with public health and primary care to do that through the local integrated strategic partnership board. So very important subject, and very important that we work in a partnership way to really address some of the prevention opportunities, and certainly that bit about, when someone is diagnosed, how do you help them to keep well?
Thank you. Dale?
Thank you, Chair. With regards to Workstream 1, that's been happening primarily in Newport, what results have you gathered already from what's been happening, and how will that be rolled out in Monmouthshire? Because it's two very different places. And Workstream 3, when you're talking about the connectors, who are these connectors, and have we enough of them?
Lovely, thank you very much. So initially we were asked when the Dementia Care Pathways was launched to choose an area, and as I said, that was influenced by the area needs. That was only for a short period. So we did that for about 3 or 4 months. And then it became very evident you can't look at one area in isolation. Every area, has an effect on another area. So we took the principles of that citizens' engagement and embedded that within the dementia-friendly communities where we've got representation from each one of our boroughs. So the principles apply now across all of Gwent. The learning that came from that was that we needed different approaches for different areas. And it wasn't, one suggestion was about setting up a patient panel where people came to us and offered their views. It was very much about we needed to flip that on its tail and we need to go into areas. So, for example, our synagogues or our maternal or maternity services, or because each one of those areas would be touched in a different way around dementia care. So we then chose a approach where we went into each one. As long as we had an invite, we would go in, we would take their view, identify what's needed to be done, and then form that into the action plans that we talked about. So it started in Newport. It's very much now across Pan Gwent. Hence, one of the learning was the dementia community hubs. We needed somewhere central for each community to know what was going on, where to get help, where to get the signposting, geographically, that it was accessible to the main population of those areas as well. And then the feedback from those individual hubs will dictate to us where our priorities need to go. Okay, thank you.
Thank you, Dale. Have you got a supplementary?
The next one was about the dementia connectors.
Sorry.
In answer to your question, it won't be any surprise that we don't have enough dementia connectors to fulfil the current need. There has been recent additional funding that's been given to us from Improvement Cymru to develop a specific role around learning disabilities in dementia, where we know the prevalence rates are really high and we didn't have specific services, and where we've got gaps in our current model. So even though we've got the funding for it, the model is aligned to the memory assessment pathway, which is currently managed by the Alzheimer's Society. So there's been some vacancies available. So it's not about the funding. There's been recent interviews that have taken place, and I believe each one of those posts are now recruited into. So I can expect to see an increase in those the take-up of those dementia connectors. But it's also something about raising the awareness of the connectors and the purpose of and what they can offer. At one stage it was offered at a point of diagnosis. It could be really overwhelming and people were like, this is too much information, this is not the time I need it. So it was about making people aware of that dementia connector model is there, it's accessible, and that's a time when you need it in your journey. Does that answer your question?
Thank you, Dale.
It does. Thank you very much.
Thank you.
Maureen, you're next. Thank you, Maureen.
Thank you. What I'm going to ask you is, in a magazine recently, it said that it's most important that you get your hearing attended to, because if you don't, if you lose your hearing, then you're more likely to get dementia. Is this correct?
It is, absolutely. So there's a high correlation between if you've got dementia, it affects your hearing loss, because as you would appreciate, changes within the brain, and it affects that pathway for your hearing. But also there's a lot of research currently, so hence the item that you would have read, where we know that if you can improve somebody's hearing really early on and recognise a difference, then that has a really positive impact on the likelihood of you. One of the risk factors that was raised earlier on about preventative model was if we can identify that, respond to that need in a timely manner, then that will reduce. So some of the work that we're taking place at the moment, very much part of that dementia pathway, but also our learning and development, is our audiology team are delivering a dementia experience program, which very happy to share with you, and you're more than welcome to attend, by the way. And we use equipment that that simulates what it's like to have a hearing loss, how that impacts daily living, but also the screening process and how we modified that screening test for people with any cognitive decline. So absolutely is one of our preventative models and our aims to improve accessibility to those things.
Well, I got a hearing aid there because I had an accident, and I was talking to somebody one day and they said, oh, I've lost hearing in one ear, but it doesn't matter, I can hear with the other one. But it does matter.
It matters, but you're absolutely right again that you're hearing the brain's an amazing organism in as much that it can modify and correct, develop different pathways to adjust to that. But then again, if your brain is having to do all that extra work, then other areas of your brain may not be functioning as well as possible as well. So definitely an area of research, improvement, and very much on our pathway to raise awareness of.
Thank you.
Thank you. Have we got any? I can't see any more hands up. Are there any more questions? We've got guests. We've got John. I think you're still there, John. I think we've got. Who else have we got as guests here? Sue. Yeah, Sue. Have you guys got any questions?
Can I ask a question?
Of course you can. Yes.
Obviously, there are local dementia-friendly groups, and I'm part of one and want to be part of another group. How do you collate? How do you keep the contact between those groups? Because they're doing tremendous work, but I just don't see the collation between yourselves and those groups on a regular basis.
I was just going to take myself off mute then. I thought it was on Teams, sorry. You're absolutely right, and for the purpose of today, I did a little bit of scoping to see the amount of work that's going on in Monmouthshire, and there are again incredible groups of people and lots of variation between Skittles group that's dementia specific, or memory cafes, the physical education leisure centre scheme, for example. So there's an incredible amount of work. So that's then collated by the dementia friendly communities. So we have a monthly meeting where, again, part of the Padlet that I mentioned earlier on, we're inviting, and this is in its infancy, so it's, if you haven't seen that, again, it's an opportunity for our comms team to share that. So within that Padlet, we invite people to say, send information to us, which we upload, and we'll say these are opportunities that are taking place in your area. This is work that you can be involved in either as a volunteer. So for ABUHB, we've got a Friend in Me volunteer service, and they've got a whole list of opportunities that you can volunteer and get involved with, from telephone befriending to one-to-one in hospitals, in care homes, in our community. So I could give you a whole list of things that are going on in Monmouthshire currently, and we're uploading that to our Padlet to say to people, have a look at what's going on, and we're sharing that through our social media challenge as well as using already opportunist things like our Facebook. So if you look me up on Facebook, you'll see I live in Monmouthshire, so I regularly share, as you'd expect, things like the Tithe Barn in Abergavenny is currently got a community cafe for Parkinson's, dementia, cancer care, etc. And we want this to be something that's not dementia specific, where it's a whole well-being opportunity to engage with. So let me summarise. Padlet, ABUHB internet pages, as well as our regional partnership board sites, offer a whole range of opportunities to engage. But the dementia hubs, I would like to think, again, in its infancy, but that should be your one-stop shop to say, what's going on in my area? How do I access this? And who can you signpost me and direct me to?
Thank you.
Thank you. Are there any other questions? Is it my turn? Oh no, Jackie. Yeah, hi Jackie.
Thanks, Chair. I just want to follow on from the last question. How? I mean, I'm not aware of who. I've been up to the Abergavenny hub when it was being launched. I'm not aware of any other contact bases or hubs on Severn side. How do people actually find out about? I mean, I'm not aware of who our Dementia Champion is. We're really keen on becoming, because I'm the Older Persons Champion, we're really keen, because we've got the Severn View Park Care Home just down the road, to become dementia friendly as we can, but there seems to be lots of things going on that there isn't connections between them, and it's all very well to say you can go to the hub, you can go to this, that and the other, but it would be much better if it was actually centrally kept, i.e. in Caldecott Library, for instance. You know, lots of people go in and out of there to get their, you know, sort of various colour sort of compost bags and all the rest of it, or to get books. We don't seem to have a central point on Severn side, and I would like to actually maybe get some links, or perhaps you could give us some links so that we can spread the word. I'm just worried that there's a lot of duplication going on, but there's also a lot of carers and people with dementia that don't know the sources of support out of there. So thanks.
And I would absolutely echo that. We still meet too many people who say, I didn't know that was going on in my area, how do I get help, how do I get support? And it's the greatest challenge that we have. The Dementia Hubs is in its infancy, so we've had a 6-month pilot of that. Initially, we were ambitious that we would be looking for each, so for Monmouthshire, we would be looking at 3 hubs. So we'd go north, south, and Monmouth itself. So Chepstow, Monmouth, and Abergavenny would have been our aspiration for that, but because of the resources and the funding that was allocated to us, we had to scale that back. So for the initial pilot, we went for 1 hub in each one of the areas. So when additional funding has been sought, and it went out for expression of interest and tenders, and the Alzheimer's Society has just secured that tender. So they are currently scaling up that model, but with our aim that there will be 1 in each one of those areas. In the meantime, whilst that work is going on, there's specific opportunities sharing where we can, but in Severn View itself, as we speak, there is a review scoping exercise around capital programme and where our priorities are and where our future spending is going to be. So again, continuously evolving programme, looking at the priorities, and that will be part of those discussions that are taking place today. But honestly, it is a challenge for us about getting this information out there. Although we use QR codes, we've got intranet, we've got Padlets, we've got the hub, which is based in the Abergavenny Wellbeing Centre at the moment, which again multi-agency, and we've got leaflets and signposting. Still, we are not having the uptake that we would like to see. So I'm very open to suggestions on how we can scale that up. But we are using our comms team, which has got thousands of contacts, and our regional partnership board contacts to try and deliver this message out there.
Thank you. Jackie.
Can I just come back very briefly? I think you're trying to reinvent the wheel. Perhaps setting something up in the Wellbeing Hub, when you've got a library, you've got the MCC hub in Abergavenny. You know, it's what, 40 minutes from Caldecott to get to Abergavenny. When you've got sort of little bases in local communities that you could have, you know, an exhibition, or you could have bits and bobs that, you know, people would get access to. Councillor Crook and I were very. We went to Chepstow Hospital on last week to see the smart sort of technology, assisted technology, and some of the stuff to enable people to stay at home if they've got memory problems, and for their families to support them to live as independently as possible. It's not, you don't need to set up something else we just need to build on what's there already. And in the meantime, people are falling through the net. I mean, I've had sort of neighbours that have had very challenging times with their relatives. And if more preventative stuff had been put in place, probably the relatives wouldn't be in care homes now. But there was nowhere to support the families. And I just think we're missing something. So please, instead of just setting up things in sort of competition with one another, build on what we've got. Build on sort of access points that we've got in our local communities. We don't need to be, if you've got somebody with significant dementia, to get them into a car, to drive up to Abergavenny, and then maybe the person that you want to sort of talk to is not there. I just think it's very stressful, and I think we should be keeping things local. We should be keeping things getting things as easy for people as we can. But I really would welcome some contacts within ABHB to actually drive some of this forward. We've got a group of people within our local male voice choir that are very keen on becoming dementia friends, and we just want to drive that forward too. So whatever you can do to support that, I would be very, very appreciative. Thank you.
Thank you, Jackie.
Thank you, Jackie. I'm going to...
Just to add to what Amanda has said earlier, I mean, I think the hubs are important because it will be different methodologies for different people, because people access information and support in different ways. What we need to do is understand the feedback that you've just given us, that actually for your population and your community, there is a very active library, and actually there might be another way to do this. So whilst we launch the hubs and try to create that local feel through, having perhaps 3 in Monmouthshire, it's what are the other things we can do in the meantime to use local facilities, local communities, and we won't have all of that knowledge. So the more that, through your connections, through, the engagement of people like yourself, Jackie, in the dementia pathway will mean that we can get this right for people, because we know it will differ for communities, but what we need is help to understand what does each community need, so we can start to design strategies to communicate, to make sure that there's the availability of information, but also to make sure that there's support. So that's really welcomed, your feedback. Thank you. We'll have a look at Sevenside and see what we can do that's a little bit different.
Thank you. Thank you. Are you happy with that, Jackie? Thank you for coming back to us, Jackie. I hope you're feeling a little bit better. Are there any other questions? No? No? Okay. So it leads me to my final question. I'm mindful of time because I know you've got to go, so it won't be a long question. So just kind of quickly looking at the stats for Monmouthshire specifically, now these figures I'm about to give you are kind of assessed in 2018. I don't think they've been updated since, but the projected figures for people over age 65 for Monmouthshire for 2025 are 26,356. For 2030, 5 years from now obviously, is 29,346. The existing provision we've got is being improved, but it's the existing provision. It's like for like, so the care home that we built in the new Sevenside care home is an excellent facility and probably state of art, but it is effectively numerically like for like, and yet our population is growing up. I suspect these figures are wrong, in as much as that, only from living in a community and seeing how Chepstow's developed in the last couple of years, the amount of houses built and the transition of people moving in from Bristol and so on and so forth, I would imagine the population's gone up. Where I'm going with this is, obviously there's additional pressures. From my own experience, as a carer, I took that. I never thought I had the skills or ability to care for somebody, to provide personal care or look after somebody with a condition like dementia. I didn't think it was possible, and of course I didn't do it on my own. I did it with my family. I was surprised what we did, but that's what people would have done before the invention of healthcare, universal healthcare at the point of access. My point is this, is that overseas, I'm slightly being abstract now, overseas if you go to places I guess what I'm trying to say is there are examples where people are encouraged. There are financial incentives to encourage people to care for their elderly people. We don't do that. And that really, I find that very, very odd, frustrating, because the expense involved in providing care up front for the local authority is enormous. Tremendous amount of money we spend on it. Hundreds of thousands of pounds a year on single people, because care costs on a monthly basis are exorbitant. It would be cheaper, certainly, up front, to assist those people who want to, through sheer love and determination and circumstance. Of course, it's not for everybody. Some people don't want to, but for those that can and do want to, or are capable, or you believe, or the state believes are, why don't we do that?
So there is no doubt that if you look at the 10-year population projections at a Wales level, there is no doubt that there is going to be a growing need for people who are frail, have multiple comorbidities, and Wales has to develop really strategies now to think about how we meet the needs of people into the future. I staunchly believe in the NHS, because I've been doing this a very long time now, but we can't do it alone.
Exactly.
And we have to do it in partnership. But that partnership is not just about health and social care. That partnership is about the voluntary sector. That partnership is around families and communities, and how we can provide the support in a very different way. It's beyond me, because obviously it is something that would need to be looked at politically, but in England there is something called direct payments. I don't know if that's coming for Wales, but there are ways and means of looking at this differently. From my perspective, outside of the political developments, I think we as a health board, along with our local authority partners, need to be working more at that community level, and that's certainly part of the plans we have to move forward with. How do we deliver care at place, and what does place mean to people? And therefore, how do you make sure that the services come to place and not into an acute setting? Because we know our hospitals are already very stretched. If we don't address how care can be provided more holistically in the community, then our hospitals are going to just, they're going to boil over, because we won't be able to cope with the demand. That's not to say that we shouldn't have hospital care for the right people.
Of course.
But the most important thing is that we're able to provide that holistic wraparound care from a health, social care, carers, voluntary sector, people perspective, in as close to people's homes as possible. So I think it's a broader political question tied up in how do we work with you at a Monmouthshire level, at a town, a village level, to start to think about how we provide care differently in a way that's much more inclusive, but absolutely supporting people to do the right thing. If they're not able to provide that care, how do we then provide the support to do that for them? So I think there's a broader question. We're definitely developing plans around a place-based care model, and through the integrated services partnership boards within each of the local authority areas. But for me, I'm a community nurse by background, and I think the community is where we need to invest and where we need to provide the support.
Yeah, I wasn't looking to draw you into some political controversy, even though I forewarned you that the Argus are probably watching everything that you say or whatever. But I guess the broader point is that I'm sure Monmouthshire would happily engage with any pilot schemes or anything like that to effectively prove to Welsh Government there is potentially a different way by looking at best practice, not necessarily just in England, but in Singapore or Italy and stuff. And that's just not about the care itself, that's preventative measures as well, whether you've got people living having a Mediterranean diet, or whether it's effectively, it's beyond just not smoking and eating healthily, it's what you eat. as opposed to how much you eat, or you know what I'm trying to say effectively, or encouraging people to play more paddleball or whatever they do once they've retired, working closer with U3 and all that kind of stuff.
I think it's the area of influence is the important thing, isn't it? It's where we take this information and how we use that information. So where we feed that into our governance structures and how we feed that back to Welsh Government, so that the Welsh Government group then can influence some of those plans going forward. But it's not just about the services, but it's about having appropriate accommodation. And we've heard about the Severn View as an example from Monmouthshire. So how do we create more opportunities for people to stay in the area for as long as they can and live as well as they can? So it's the influence for me and feeding that information back.
And I think the work that our Director of Public Health is doing will start to pull forward some of that work, and it's really fantastic to hear that that you want to work with us in terms of what the future could look like.
We do. I guess my concern is, and you know, you could have really, I agree with everything you said. The only thing I would disagree with is in the future. I think the future is now. I think it's happening now to us.
I agree.
And I think to pretend that it's something we can kick down the road a little bit, the can down the road, it's too late. It's happening now. As you know, all the evidence suggests that from when you engage, and as Jackie said, really, people are concerned now about what's going to happen. So that's why we want to come and visit you to drive you nuts and say, this is what we were looking for, but we're really interested in what you do. We genuinely are.
Absolutely welcome the opportunity.
I was only going to say, with time in mind, that I was going to wrap this up, unless there's any other questions, and ask you to invite us along, including Jackie or any of the councillors as well, to come and see what you're doing, and we can carry on this conversation, and then for the next 2 years, invite you back and see what progress we've tried to make. Is that okay?
Could I just add one thing, just to reassure you, this isn't in the future. We are doing work now with the ISPBs to look at how we provide care differently, and we have a number of programmes in place, so very happy to work with you and to invite you in.
Thank you so much. Thank you both, Amanda and Jennifer, for coming along.
Thank you.
It was your first go at Scrutiny, right? Yeah, you survived. You lived it. You can go home. You have that adrenaline rush driving home. Yeah, you'd be putting on your favourite track or whatever in the car. Listen, thank you so much for coming along, and I'll let you go because I know you. But yeah, really, really appreciate it. Well done. Thank you, guys. Right, so next on the agenda, I won't see you out because I've got to carry on during this meeting. But thank you very much. Right, so. Yeah, thank you. Okay, all the best. Number 8 on the minutes of the previous meeting. Thank you. Yeah.
I'd like to move that we accept those minutes.
Okay. Yeah. Have we got a seconder? Is everybody still awake there? Sure. Yeah. Yeah. Thank you. Thank you. Brilliant. Excellent. Yeah. And then, so number 9 on the agenda, we've got Public Services Scrutiny Committee Forward Working Plan, Hazel, action list.
Okay, so really busy. On the 10th of July, you've been invited to Place, which is a joint scrutiny meeting. That's this week. There's 3 items on the agenda, but the one of relevance to you is one that you wanted to scrutinise and they wanted to scrutinise, which is the local flood strategy. So feel free to join, 10th of July, 2 p.m. Next one is we've been given notice that Nyren Bevan Health Board is consulting on the development of Neville Hall. Consultation phase ends on the 15th of August, really soon. So if you want to scrutinise the proposals and offer feedback, we need a special meeting this July. Dates that I have that we could offer them that are free in the diary are Wednesday the 23rd in the afternoon, Monday, and then we're looking into the final week of July, which I know is school holidays. Monday the 28th, morning or afternoon. Wednesday the 30th, morning or afternoon. Thursday the 31st, morning or afternoon. So do you want to do it? And if so, I need to offer them several dates. I can't just offer them one.
So can I make a personal request in as much as that logistically, it's very difficult to do afternoons for multiple reasons, really. But I'm going to assume other people have similar commitments. I think it's good to just get on with the day, so have the meetings personally in the morning, unless anybody disagrees with that.
So should we offer them the 3 mornings?
Shall we offer them the 3 mornings? That's what I'm suggesting. Yeah? Steve? Marion?
So the latter week would be better for me, to be quite honest.
Okay.
The week prior to that, I'm away from the 21st.
Well, off from the 3, yeah. I mean, I must add that, this is all after the event, really, in as much as that we're coming close to it, so I'm surprised that they asked for oversight at this late stage, but that's how it is, right? I think they need to, considering if you remember the last time when we had to scrutinise the closing of the 8 of hours, they were on top of that well in advance and were briefing us quite heavily. This seems to be not as enthusiastic. I'm not really sure why, but we will do it. You're right. I mean, if you're happy to do it, we will do it. Is that okay, Steve? Yeah, Jill. Yeah, excellent. She's got more.
Sorry, I've got more. We've also had an email from the Chief Exec, which is about proposed changes to the ambulance performance framework, which take place with effect on the 1st of July. So they've already happened. They're not things you can influence. They're basically around the 8-minute response time and changing that from red to red and purple and different criteria for different call-outs. So it's how they're measured on their performance. But you have had them in the past. Would you like to perhaps invite them in at your regular meeting on the 13th of October or another date at a future point to have a discussion about how it's going? Okay. On your regular meeting, possibly I could put in the Youth Offending Service report, but we also need a special meeting to invite the Police and Crime Commissioner in. Purpose is to get an understanding from her about the Community Safety Partnerships plans for Monmouthshire and how the strategic assessment led to develop them. Also the publication of the Police and Crime and Justice Plan. We want to understand her plans for police resourcing across Monmouthshire. They've given us some dates. We know that they're having a members' seminar which they want to introduce themselves, but we have some dates. We have the 3rd of October afternoon. I know the chair's just said afternoons are not great. We've got the 28th in the morning, Chair. Do you like mornings? We've got the 30th in the morning. 10 till 12, so I mean those could be goers if the committee was minded. We know she's free on those because we've been having extensive liaisons.
Hazel said we've got some goers there. Jill, sorry.
I totally agree with everything that has just been suggested by Hazel. Thank you very much. I just wanted to raise the Bowder SV situation, especially regarding what we've just been discussing in this meeting about suicide and perpetrators, victims, all the stats that are around relationships and all the things going on. So would like that to be pushed up the agenda if at all possible. I know you've tried and tried and tried, both of you. But that is a very pertinent thing, as Jackie was saying earlier and other people were saying.
Yeah. Okay, thank you. I think if I may, it's not like we haven't asked for some time now, and there are outstanding issues from the last time we met, which was a really interesting, engaging meeting to do with issues about how they statistically assess then issues to do with. All sorts of issues, including hate crime, and they were due to come back to us. I think the process of, I think we first approached them 7 months ago.
Police and Crime Commission, yeah.
So the police you're talking about?
Yeah, the police. So the police and sorry, I'm on specifically about the police and crime. Yeah. And that was we wanted to know what they were doing, then we wanted to have a broader discussion about some of the concerns we'd already expressed in this meeting. And it's not like we haven't tried and tried again. In fact, Tony's helped us. I think Hazel's been on the phone, emailed multiple times. I've been on the phone twice, 3 times. And they wanted to know what we were about, and then we've heard nothing. I think Hazel got an email probably about 14 days ago with some dates, and then we've got this other meeting taking place, which is then behind closed doors. And my natural kind of democratic instincts are that it would have been simpler and better just to have this meeting out there with all the members. We could have invited everybody in like we had today and had an open, broad discussion about all the themes that we, all the kind of questions that we had. I think it would have been a great meeting. But so I'm not sure. I don't think it was designed really to steal our thunder, but I think what we've got going on, if you look at the work programme of other committees, is there is a kind of tendency for duplication here. So the committees will grab hold of something and then suddenly we've got a seminar about it. And I don't think that's really that helpful. So maybe officers could look at that. I'm sure I'll be in all sorts of trouble now for saying that, but it's not intentional. It's done with the best of, interest for democracy, shall we say. Sorry, Hazel.
With that in mind, Chair, we've got October the 28th morning and October the 30th. What suits the committee best? And then I can go back and confirm that date and we can finally get it in the diary.
Either for me.
Yeah, that's fine. Yeah, I'm happy with that. Yeah.
Too far ahead, so just go for it. And I'll fit my life around it.
Yeah, the first date you gave, the morning.
Oh, the first. The 28th, yeah?
The 28th, yeah?
Yeah. Is that what you said, Jill?
Yeah.
Yeah.
So
okay.
And that'll be open again. That'll be open to all members as well, right? Mm-hmm. Yeah. What else have you got, Hazel?
No, that's it now, Jill.
Okay, thank you. And then we've got number 10, Council and the Council Cabinet Work Programme. Hazel.
Sorry, Chair.
Oh, sorry.
Before you go on to that, can I ask also 2 things that I don't think certainly I can't even recall the last time we had any update about it, is the Cardiff Capital Region. We're a partner in that, but we never seem to get any reports to the Council, and the Public Services Select seems to be an appropriate place to scrutinise, our work there. We don't get any reports. And the second thing is, obviously, there's also been a number of concerns, I suppose, in respect of the representatives on the Severn Bridge, I don't know what it's called, committee. How will we get them to report back to us? I don't mean report back, I mean how will we scrutinise the work that they're doing, the benefits, the disbenefits. So both of those things, I think it's really appropriate that we have both.
Okay, so I'm not gonna comment on the first one because I'm actually on that. I'm part of that scrutiny process. However, on the latter one, actually, I'll tell you what, Hazel, if you go answer the first one.
So on the first one, we have a joint scrutiny committee, which is called the Corporate Joint Scrutiny Committee. So we've got CCJs now, and we've got representation on that CCJ from all councils across the Cardiff Capital Region. So we have 2 members from Monmouthshire that sit on that, and then 2 from everybody else. One of those is your chair. So they have responsibility for the scrutiny of that. So without...
Just to say though, sorry to interrupt you, I'm so sorry, I've got to quickly take a call, Hazel, but and with respect, for example, if we take the Police and Crime Commissioner, we've got a scrutiny member on the panel there, I've got Police and Crime panel members, but we still having the Police and Crime Commissioner in, and also potentially the Chief. So I don't know that's really that really gives all members the opportunity to understand what's going on. There is no mechanism though for those members to report back to the council, Hazel, so I wonder if you could give that some thought and consideration, because obviously we've just had an email, haven't we, about the £5 million interest, which the £5 million fine issued by the High Court, which is coming out of the interest balances held by the Cardiff Capital Region. I'd be really interested to hear about and scrutinise, you know, the benefits for Monmouthshire in respect of, because obviously we contribute financially to the Cardiff Capital Region, and the outcomes, I think it would be really appropriate for us to have an opportunity to appreciate that. That's just my thought anyway. Thank you, Chair.
I mean, you make a good point. The difficulty I've got is I'm on that committee, so you'd have to have effectively somebody else to chair the select, because...
Well, I guess that's what you have a vice chair for, potentially, Chair, isn't it? When, you know, you have to kind of step aside. I mean, you know, I get that we've got sometimes... In fact, on all of the things, you know, there'll be, you know, we've got an elected member in our Bevan. They don't necessarily represent us.
No, okay.
We've got, you know, there's all of those things, but that doesn't necessarily mean that we, as ordinary elected members, get to hear what is happening and get the opportunity to scrutinise it. Otherwise, I suppose we could hold you and anybody else who's on that committee to account, if appropriate. I don't mind, really. I just think it needs to be considered by the council somehow. Thank you, Chair. And I shall leave you to give that consideration.
All right. So, but we do have a Senate, sorry, if I may, though, we do have a Senate committee, though, don't we?
We don't, but the Senate have scrutinised it. There are other mechanisms where it's been scrutinised.
Well, I mean, I'm so open-minded. I tell you what we're going to do, Francis, is if obviously with the backing of the committee, I mean it's entirely up to the committee, is let's take some advice to see whether or not this is actually for us, because I'm not sure it is. I take your points on the latter issue though, about the Severn Bridge. I mean, so I'm not dismissing it. I think we should go and take some advice. Jill, I can see your hand. I'm going to come to you in a minute.
Just, I want to wholeheartedly agree with what Francis just said.
Okay.
Because I'm on Close, but I can't come back and report everything that we're told on Close. So the fact that we do need a presentation from WAST and to do with, you know, the specific issues. So I agree.
Let me just go and check them with legal to see whether or not all Democratic Services or the Monitoring Office, whether or not I want to be on the right side of whatever we do here. Okay. So
yeah, that's absolutely fine with me. But I think though that, and I'd be interested to know, you know, where we have got representatives on the council, are we expecting them all to bring RAC reports? I don't think that we do. I don't think we have a mechanism for that yet. Where it's kind of like you know, a public service partnership type approach that's delivering benefits or effects Monmouthshire, that maybe I've misunderstood the kind of remit of the Public Services Board. I'm very happy to take advice from Hazel, but maybe it is something we could explore a bit further and then come back on. Thank you very much, Chair.
No, it's okay. I understand you, but it's a huge, what you're asking is quite a huge piece of work. So I'm going to take advice on it because I'm just genuinely not sure. The latter part on the Severn Bridge, I mean, you know, you're pushing an open door here. It is really, really frustrating to understand what exactly is going on here. I've written to the Chief Constable of Avon Somerset Police and Gwent Police, asking them about effectively the resource implications of overseeing the traffic on the bridge, you know, heavy goods vehicles. I've not had any response. I also wrote back to National Highways asking for a response, and I just didn't get an answer. So they've simply stopped communicating with me, even though my questions have been reasonable, I think, and straightforward. Or they come back with fairly opaque answers. So it is really, really frustrating. I don't know what's going on there. I don't understand why their approach seems to be so reluctant to engage with the democratic process, and I appreciate as councillors we're not going to know the precise details of how you effectively support a bridge, what the cabling implications are, what the longevity of it, but we rely on certain reports and evidence that comes before this committee. We were told last time at this committee, if you remember, that we were going to put ANPR cameras on there. They effectively introduced the legislation, which incidentally, if you look at the legislation, does not include buses, even though they said it did. And at the same time, they didn't actually introduce those ANPR cameras. They said they had, but if they have, I'm not really entirely sure why the police are there, to be honest with you. Why they've got 2 police cars at the Severn Bridge the resource implications are huge. So the thing looks a bit of a mess to me, and there is a democratic deficit. So I think, I think that stands up. But I don't want to go off on my hobby horse again and start moaning about the first seven crossing. So I think what we should do there is effectively write then to the National Highways CEO and the Minister and ask them, what's going on? Effectively, I'm sure we can collectively put a letter together from this committee asking them effectively why they've set this up and where is the electoral representation of any of the local authorities and including the police in that as well. What do you think?
I think that's a really good idea, and if we can't have Cardiff Capital Region here, maybe we can do the same with them, because whilst we do have representation and quite a bit of representation, I'm not sure that we really get. I mean, I think that email we had about the fine was probably the first thing I've heard from the Cardiff Capital Region in, well, I'd like to say quite some time. I'm really interested to know about the benefits that have been delivered for, cost vis-a-vis the input. Obviously, we financially contribute to that, and we are rather strapped for cash in all directions. So it'd be good to know. No. Thank you, Chair.
No, thank you for your input, and thank you for being so persistent with the issue. But I will take advice on that, Francis. So watch this space. I will be in contact with all of you very soon. Is there anything else, Francis? Hazel, Eva. No. Next meeting, which is not until Monday the 13th, which probably isn't going to be the case now, is it? So officially, I've got to ask you, until we hear otherwise, the next meeting, if you're satisfied with it, which is going to be Monday the 13th of October, 25 at 10 a.m. Is everybody happy with that?
Subject to all those.
Subject to all the other things that have come on the diary. Everybody? Yeah? Give me hands up. Yeah, Steve? Yeah? Listen, guys, is that the end of the meeting?
Sorry, Chair. Just to say thank you very much for Hazel and everyone else putting that extra column in the upcoming work, so that people are putting more information in for us in response to us, then being able to identify which ones we want to scrutinise. I just want to say thank you very much.
Okay. Thank you, Jill. Thank you all for your input. Thank you for the guests. Nice to see you, John. Jackie, everybody that's come along, Sue. It's been a long meeting today, but I think it's been a really helpful meeting, a productive meeting, and we've discovered things that we didn't simply know before. We're more informed as a consequence of this meeting, I think. Sorry, I didn't have my mic in front of me. Like I say, until we know otherwise, I'm going with the original plan that we see you in October. So I'd like to wish you all a restful and peaceful and enjoyable summer. Bye-bye, everybody.
Chair, bye.